Good afternoon. I would like to welcome all of you on to the second webinar organized by Section for Peripheral Nerve Surgery under the auspice of European Association of Neurosurgical Societies. As we all know, we successfully organized the very first webinar of ENS, also devoted to the field of peripheral nerve surgery. This is the second one. We already have a plan for the third one. We will say that at the end of our webinar session. And I'm very pleased that we have an increasing number of participants. So far, I can see here 138 participants on this webinar. And we are going live on YouTube also. I'd like to express my sincere gratitude to ENS, especially to the people from technical support, and especially to Anna for coordinating all these activities. And my special thanks and my personal feelings goes to all of you, my dear friends, peripheral nerve surgeons, brothers in arm. And I would like particularly to welcome now our transatlantic guests, Professor Alan Belsberg, Professor Eric Zager, Professor Marian Sokolovsky, and we are all from European Section for Peripheral Nerve Surgery, panelists and lecturers. I would like to express my gratitude to Nora for creating this webinar and raising this initiative to discuss about this very challenging topics in not only in peripheral neurosurgery, but in general, especially because of the transdisciplinary correlation with field of vascular surgery. And we have a special guest within us in this webinar. This is Dr. Ilya Strinera from Clinic for Vascular Surgery and Endovascular Surgery from Medical Center of Serbia, University of Belgrade. My great friend, surgeon who has a lot of very big experience, vascular surgeon who has a very big experience in all these cases. And I have a pleasure to say that we are operating, even today, we operate one case together in the morning. It was not a case of thoracic outlet syndrome, but it was a complex case of vascular lesion of brachial artery and median nerve with reconstruction, grafting procedure. And we have a very rich schedule, and I wouldn't like to take your time anymore for enjoying in this exciting topic, in the exciting webinar. I would leave the floor to Nora to continue with presenting the lectures and to start with presentations. Nora, please.
Thank you, Lucas. Good evening to everyone again, to the European neurosurgeons. So we're happy that you turn on and tuned in. And we are more than happy to have really huge experience present in this webinar from Europe, from Transatlantic. And I think we have one of the most experienced neurosurgeons in thoracic outlet syndrome in the world present here in this webinar. So we look very much forward to hear from them and to learn from their experience and to have everyone on board and to possibly help to demystify the syndrome. We start with some propedeutics to go through anatomy, different types of classification and how diagnosis and diagnostics can be performed. We will talk about different cases, and we will also discuss when to operate, when not to operate, what are options of conservative management in the syndrome. And then we go through possibilities of surgical techniques to show you where we possibly find consensus in therapeutic and surgical management and where are controversies in surgical technique. Then we also have nice cases from Alan and Ridvan. And we are very, very happy to have Professor Chinara here to give us the vascular surgeon's perspective and to discuss and help us with the discussions whether the vascular co-pathology are possibly neglected by neurosurgeons. We look very much forward to hear everyone's opinion on that. So I think we can start with Natalia, who prepared the anatomy for everyone. Thank you. Greetings to Novosibirsk.
Just a second, I will share my slides. So, good evening, dear colleagues. Today we have very interesting and challenging but complicated topic of peripheral nerve pathology.
Natalia, we cannot see your slides yet. Maybe something.
Sorry.
Please try again.
Sorry.
Perfect.
Before the starting of Natalia's presentation, I would like to say to all participants, now we have 178 participants to introduce their questions or comment to the, you have a special field with question and answer rather than to the chat. And we will answer gladly to your, we'll be happy to answer all these comments and to discuss all those comments and to answer all these questions. Natalia.
Perfect.
Thank you. So, sorry for delay. Today, I'm gonna tell about anatomical aspect of thoracic outlet syndrome. Thoracic outlet syndrome is caused by compression of neurovascular structures at the thoracic outlet. Thoracic outlet contains three important structures: subclavian artery, subclavian vein, and brachial plexus. So as they travel from the upper extremity, from the upper mediastinum to the upper extremity, they go through three important spaces, which can be potentially responsible for compression. So the first space is interscalene triangle, the second is costoclavicular space, and the third is subpectoral space. The first and main entrapment point is interscalene triangle. The scalene muscles are situated on the both sides of the neck. There are three of them: anterior scalene muscle, middle scalene muscle, and posterior scalene muscle. So these muscles are originated from transverse processes of C2 to C7 cervical vertebra, and they have insertion point on the first and second ribs. So anterior scalene muscle and medial scalene muscle inserts onto the first rib, and posterior scalene muscle inserts onto the second rib. And the main function of these muscles is rotation of the neck and also flexion of the neck forward and laterally. Also, these muscles are participating in forced inspiration because they elevate first and second ribs during it. So if we see the picture of this interscalene triangle, you can see that the floor of this triangle is formed by the first rib, and both sides of triangle are formed by anterior scalene muscle, here it is, and middle scalene muscle. So inside this triangle, we can see brachial plexus and subclavian artery. Brachial plexus is situated posteriorly, superiorly, and more lateral to brachial artery, to subclavian artery, I'm sorry. And subclavian vein also follows the same course, but it doesn't go through this triangle. It lies just anteriorly and medially to anterior scalene muscle. Average distance at the base of triangle here is 0.67 centimeters in women and 0.77 centimeters in men. In cadaver study, this distance is a little bit bigger, is about 1.1 centimeter. So it's quite small space, as you can see. The scalenus minimus or pleural muscle is also a normal anatomical variant present in 7 to 46% of people. This muscle is located between subclavian artery and T1 root of brachial plexus. It originates from transverse process of C7 and inserts on the first rib. This muscle also has some fibers which fixes pleural dome. That's why it has this name, pleural muscle. And also this muscle can bring additional compression to neurovascular structure because it makes this triangle even more narrow. Here on the picture, you can see some variants of muscle abnormalities. For example, the insertion of anterior and middle scalene muscles on the first rib can vary and cause V or U formation because of overlapping of the inferior fibers, like here. And this formation creates a narrow space and causes elevation of subclavian artery and brachial plexus. So the pressure goes from below. Here. There is also another variant of this fiber overlapping when we can see it on the proximal part of triangle. And then the pressure goes from above on the brachial plexus and the space becomes smaller. Also, there are some cases described in literature about full fusion of these two muscles when all fibers are overlapped and then brachial plexus and artery just go through muscle fibers. Cervical rib is also an important cause of thoracic outlet syndrome, and it has been reported in 5 to 9% of patients with this syndrome. Cervical rib is a mesenchymal or cartilaginous elongation of transverse process of C7 or very rare C6 or C5 cervical vertebra. Here you can see on the picture different sizes of these cervical ribs, and usually it has some fixation to the first rib with some fibrous bands. The incidence of cervical rib is 0.5, 0.6%. 50 or to 80% of them are bilateral, and it's more commonly in women. Here is the classification, very old, by Gruber. There are 5 types of these cervical ribs, depending on the size. Costoclavicular space is a triangular area bordered anteriorly by medial portion of the clavicle and underlying subclavian muscle and costocoracoid ligament. Posteromedially, it is bordered by first rib and insertion points of scalenus anterior muscle and scalenus medial muscles. And posterolaterally, it borders by upper border of the scapula. Narrowing of this space can happen because of some bone abnormalities. For example, after fracture, bone fractures, or fused ribs or beefed ribs. So these abnormalities can be inherited or acquired. And also, the mechanism, this compression can come from some extra pressure on the clavicle. This can happen in some cases of droopy, saggy shoulders caused by poor posture or disabling illness, or in obese women with very heavy breasts. Subpectoral space compression is less important and less frequently encountered. It is located just below the coracoid process. Here it is on the picture, and under the pectoralis minor insertion. So here it is at this point. And during hyperabduction, abduction of shoulder, neurovascular structures can be compressed by neurovascular bundle of pectoralis minor muscle. And also, I didn't say about this space. Also, when the shoulder abducts, the clavicle also moves posteriorly and backwards and upwards. And also it brings some additional compression during shoulder abduction. So as we could see, that anatomy of thoracic outlet is very different, and it has some very, I mean, in every patient, it's important to find the right reason of thoracic outlet syndrome, because anatomy can be very various in different people. Thank you for your attention.
Natalia, thank you very much. Very nice picture, very nice overview. Thank you.
So Nora, please continue with the meeting.
We have one question. Can you measure sizes of these spaces by any radiological means? I think we go a little bit deeper in that in the diagnosis and diagnostic session, but can you answer parts of it, Natalia?
Actually, unfortunately, I have sizes only for interscalene triangle, and the base is about 0.7 centimeters. And it differs also on cadaver studies and on surgical studies, probably because of muscle tone, of course. And so it's quite narrow, and I think the height of this triangle is about 2.53 centimeters.
It also differs from the kind of position the patient is in. So
yeah, absolutely.
To do diagnostics in abduction or in retroversion, and then it possibly might influence that. I think there are some measures also for MRI, but we have Deborah on board, who's going to tell us. Oh no, we have Stefano first, right? Stefano is going to tell us about differences of classification. To give everyone an overview, when you read in the different literature, what is entos, what is detos, what do we understand, and where does this classifications come from? So Stefano.
Okay. Can you hear me?
Yes.
Yes.
Can you see the screen?
Yes.
Yes. As you can see in nature, sometimes you find thoracic outlet anatomy if you're quick at seeing. I don't want to go into the anatomy because it already been done. Just to remind you one thing, what happens in the venous, because many say that venous is not decompressed. So the problem in venous is understand the anatomy, because the Lisfranc tubercle, which is the site of insertion of the scalenus anterior, if you decompress at the beginning the Lisfranc tubercle, you decompress both artery and vein. You see here you have the subclavian groove and the subclavian vein groove. And here is the insertion of the scalenus anterior. So if you are able, it's not possible in all cases, that if you can reach the scalene tubercle and you detach the muscle from there, you can, with one simple gesture, decompress both artery and vein. The classification is here. We will go rapidly to arterial TOS. I'm not an expert. We have an expert, but just to tell you that can be anticipated by some symptoms. When it is severe, it is of course an emergency, but it can be anticipated not by neural symptoms, but vascular symptoms. A unilateral Raynaud with pallor, pain, diffuse capillary refill, low tension of O2 can be a warning sign for vascular arterial TOS. Then you have even more intimal lesions, claudication, emboli, and in that case can be really an emergency situation to save the arm. But the idea is that you may have a warning sign with vascular symptoms. But as I told to Nora, the devil and the holy water, I quote the gospel, and you have to render unto Caesar what is of Caesar. So if you have neural symptoms, don't do angiographic studies, because it can happen that you observe a stenosis, and then you may be led into a surgery which is not addressing the problem. So if you have a vascular symptoms, do vascular studies. The venous is different because you have no signs before. It is a sudden event. I had 3 cases about this, and it is also called an effort thrombosis, the Paget von Schroeter disease, usually affecting middle-aged men after a strong effort, heavy working, and then you have a sudden thrombosis. Can be an emergency, of course, because the patient can develop pulmonary embolism. So every treatment is warranted. And if you have an anatomy which is altered, stents are not enough because they tend to collapse. Again, I remind you that if you're able to detach the muscle from the Lisbon tubercle, then we can talk about, because the vein usually is also decompressed. So this is the image of one case of Paget von Schroeter. Only one episode, I don't go to surgery. Sometimes if they are recurrent, it can be worth of doing, but I must have personally abnormalities in the area, bony structures or what else, but we will listen to the vascular surgeon later. In that case, in a vascular surgery, an emergency, everything is warranted because the patient risks to lose the arm. So the first rib removal probably takes its only indication, in my opinion, of course, when you have an emergency. When you have problems with the arm, everything is warranted. You better go from supraclavicular and transaxillary to approach both sides of the thoracic outlet and do whatever you need to do. This is a nice picture. After removal of everything, you see how T1 and C8 is completely free, and in the bottom you see the pleura and then the subclavian artery. Then we have the classification of the neural. The first, I call it atrophic, Atrophic is because you have a damage of thenar eminence, hypothenar, and the first interosseous space. The only place where you can have the damage is the proximal portion of C8 and better T1. Probably the thenar eminence is only T1, is not C8, and probably I can say in young people, and I will say you why later, they have only, T1 has only or almost only motor fibers. What happens in this case, this is the cutting edge of the scalene muscle, and probably T1 is the first one encountering the cutting edge, and then it acts like a buffer protecting C8. and then you have an atrophy of the thenar eminence. Otherwise, we cannot explain how we have two different populations of this atrophic TOS. One is the adult, and they pass through a period with the fourth, fifth finger numbness, pain, and disturbances. And then we have another population of teens, and they behave more like a perineurioma patients, because you see here from the slides, I had young girls of 11 until 11-year-old, and they didn't say, I don't have any problem, just my hand was so meager, so atrophic, I don't know why. So it is more like a perineurioma, and they do not pass from a syndrome of irritation, pain, numbness, probably because T1 has low or nothing or no sensory fibers. Otherwise, we should think that it is another disease from another cause. These are the more reliable, in my opinion, sign in the irritative syndrome, which is not atrophy. They have disturbances, fourth finger, pain in the arm, then irritation, but no neural deficit. They are the traction test, the Tinel sign, and the hyperabduction maneuver of Ross maneuver. There are other maneuvers like Hudson, Halstead, done with the patient in the sitting position and to check the vascular incidence of the maneuver, but I don't rely so much on vascular symptoms. I say that you go to Caesar, what is rendered to Caesar, what is of Caesar. Neural symptoms require neural investigation and neural way of thinking. How to diagnose this? This is irritative, probably, yes, but we are not sure. This is a unilateral fullness of the venous compartment. Then the main difference between the disputed and not are the radiation in fourth and fifth finger, and in my personal opinion of the series, clear anatomical problem. In disputed, often you don't have radicular pain and you have an absolutely normal anatomy. In this case, if you have an hernia, C7, T1, what are you doing? I have collected some cases, very few cases of this level herniation, and I asked specifically all the patient, every one of them refer pain around the scapula. So I have built in my mind the idea that scapula is done by compression of C8. If it happens to you to have this herniation, rare, but they happen, ask the patient if they have pain around the scapula. But in that case, of course, first you operate the hernia. I defy you. I think I don't dare to operate first the thoracic outlet before in the situation of this kind of herniation. Sometimes you have a double crash. When you have a suspicion of a double crash, this is a better evidence that you may have a thoracic outlet. Instead of trying to define whether you should operate on the carpal tunnel or ulnar nerve, think that when you have the suspicion of a double crash, this is because you have a thoracic outlet of the irritative type. The Gruber classification has already been said, so I don't lose time. But in my classification of the irritative syndrome without atrophy, you must have abnormalities like asymmetric rib, like in this case, a strong piece with a Gruber type 2, you have a piece of a floating supranumerary rib from C7, you see how it's hard. And in that case, of course, you have to remove your obstacle to the plexus. Or you may have a sequelae of a clavicular fracture that you have overlooked, or the patient itself, himself or herself has overlooked. Or you must have you can have a monster rib, a single monster rib. This was a very strange case because the compression is shown here was on C5, C6. It is very rare to have a compression of C5, C6, because normally C8 and T1, and so symptoms are from the fourth and fifth finger. But this is also part of irritation syndrome. This is another big piece of bone. See how it's compressing the subclavian artery, but in every case of irritative syndrome, you must have an abnormality. Here, another case, of course, then you go and decompress. I don't want to take the breath from the mouth of those speaking of surgery. These are all other alterations I try to represent with the surgical field. Here the bands, here anomalous bands. Here again an anomalous band. And in that case, I don't want to hear about conservative surgery. If you have an irritative syndrome, if you have an anatomic alteration, there is no point in giving you 1 hour of your time or 2 hours of your time every day for months to the physical therapist, unless you have fallen in love with her or with him. In that case, it is warranted to do conservative surgery, therapy. Otherwise, I always recommend surgery. And then we go to the crying situation. This is really crying, the disputed TOS or cervicoscapular pain syndrome. In that case, you have practically nothing, no anatomy, no alterations, many other symptoms like chronic fatigue, the tremendous fibromyalgia. Everyone talks about fibromyalgia, but no one knows what it is and where it finds. Seronegative autoimmune disease like thyroiditis. Those patients have signs of autoimmune disease with anemia perniciosa and thyroiditis, or some impingement on the shoulder. These are really patients with problems because they are almost stalking the doctor. Sometimes you really cannot get rid of them. In any case, you try to tell them to not persuade not to do surgery, but they think you are the wizard that should heal them. And this is a big problem. Anyway, the two hallmarks are not radicular pain and anatomy absolutely normal. In this case, I tried everything. These are bilateral Raynaud cases. This is suspicious. This edema is always suspicious because this has nothing to do with thoracic outlet syndrome. And then in this case, I recommend treatment with supporting with the bra, wearing a rucksack, avoid hyperabduction. Not all the cases are like this lady, of course, and probably unfortunately, but I don't want to say anything else because it could be dangerous for me. And then I try to convince not to do any surgery. However, without promising a result, sometimes I have moved to PT and then I go to surgery. Reading through the literature, they say there is a surgery with a high number of complications, and therefore is not a surgery that should be done very easily. But this is not true. Sorry. If we look at our complications in the number, they are very few. The only important complications are a lymph leakage. In 2 occasions, we had to reoperate, and in 1 occasion to close the thoracic duct. But apart from the leakage, the other complication always warrant, when you have a strong stalking and desperate patient, the exploration. Sometimes you may have a surprise, like in this case, that you see a very tough additional band, and in that case, the patient was right. So if you are able to perform an exadjuvantable surgery without giving any complication, you will probably be warranted in surgery, even if you don't believe in it so much, but just to make the patient happy, which sometimes can be also a strategy. Then just rapidly a case. This was a lady, a chemist, and she had the perfect irritative syndrome. So I operated on the thoracic outlet, and I found nothing. You know, a case when really you don't find nothing. An anatomy like a book, a studying book for the first year medical student. Then, unfortunately, I did an MRI and I discovered immediately below the clavicle from the medial cord a tumor which was operated like a benign, but it was unfortunately a malignant tumor. And then now this patient is okay, but she underwent radiation and so on. So in that case, I did a mistake. This is the only one diagnostic mistake in my life, in my experience, because the presentation was the same of an irritative syndrome of the thoracic outlet. So the finishing, just to remind you how time passes, it seems yesterday when I was in Colombia with my kids, and look at how they are now. Thank you very much for attention, and my word to Lucas and Nora.
Thank you, Stefano. Excellent presentation. Previously, Natalia, also your presentation was a great job. And we have two questions and comments. One is, if I understand correctly, who if remove the whole single rib? I don't understand really what is the question, but it is written who if remove the whole, maybe why if remove the whole single rib. And the other question is from this question is from our colleague Muhammad Zafi Memon, and another question is from our dear friend and colleague Peripheral. Scapular pain may also be part of C7 compression from herniated disc.
Yes, C7 compression from herniated disc means a very ordinary disc, C6, C7. I do not exclude that in some cases, they can refer periscapular pain, but this is not usual, and it is together with other symptoms. But if you ask those with C7, T1, from now on, when you observe a patient like that, try to ask him or ask her, and then they will tell you specifically that they have a stabbing pain in the scapula. So probably I'm wrong, but I've done in my mind that the atrophic comes from T1 and the scapular pain from C8.
Thank you, Stefano. Any other comments?
Stefano, thank you very much. I just have one short question, of course. How many ribs did you remove in neurogenic cases?
Without, you mean normal first rib? No one.
Okay.
Normal, no one.
Thank you.
Nora, please continue with the next lecture. Nora.
Yeah, we have the great talk on diagnosis and diagnostics, and there is Deborah. Hi, Deborah, from Dubai. Put your microphone on. We'd love to hear how diagnosis and diagnostics can be accomplished.
So, hello from Dubai. Thanks to Nora and Lucas for inviting me to this webinar, and I'm going to talk about diagnosis and diagnostics. And basically, I'm going to focus my presentation on the form of thoracic outlet syndrome without neurological deficits based on my experience since I relocated in the Middle East in the last 3 years. So out of 79 patients that have been referred to me with a suspected thoracic outlet syndrome, I have diagnosed 46 patients that presented a neurogenic dose. Only one of these 46 patients presented a bone anomaly, and all the others did not present any anatomical anomaly, and there were no neurological deficits. So you can imagine that to raise a clinical suspicion of thoracic outlet syndrome might be a little bit difficult, because this is known to be a diagnosis that can sometimes fool the unexperienced physicians. because diagnosis for these cases is mainly based on clinical data. Now, my starting point for assessing this kind of patients is that those without neurological symptoms, without neurological deficits, is actually a dynamic compression on the neurovascular bundle for the upper limb that is consequent to a muscle imbalance in the shoulder girdle that results from constitutional, postural, and professional predisposing factors. So I'm trying to briefly overview what is my diagnostic workup in these cases. And one of the things I start doing is that I usually focus on the phenotype. So we know that thoracic outlet syndrome without neurological deficit is usually something that is mainly predominant in ladies. And I would say that many of them present what I call the Modigliani phenotype. They have a long and slender neck, they have narrow shoulders, sometimes they may have heavy breasts, like the lady that you see in this picture here. Something else I try to focus on is the kind of profession these patients do. For instance, musicians like musicians playing the flute or the violin present this kind of posture with the imbalanced muscles for a long time, and they might be predisposed to develop this kind of symptoms. And there might be also some interesting clues in the past medical history, a history of trauma, like for instance, a whiplash injury, or history of cervical spine surgery. This is something that I've started to notice, especially in the last years. Something that I would like to emphasize is that I think there might be a difference that might be gender related in the etiopathogenesis of thoracic outlet syndrome, because I noticed that, for instance, almost all my female patients were just primary cases, and they presented with a long dating clinical history. Here in Dubai, I have done surgery on patients that presented symptoms starting 9 years before and an average as 5 years. Whereas male patients in 1/3 of cases presented a secondary development of those, 1 case after trauma and 4 cases after they had received cervical spine surgery. And the clinical history in these cases was shorter, even a few months. Now, what I really focus on is the clinical presentation. Because the clinical presentation for me already raised a red flag and triggers the suspicion that we have a thoracic outlet syndrome. So patients would report they suffer from cervicalgia. Many patients do report that there is a radiation to the shoulder blade, and I highlighted that because these already raise a red flag for me. And then the pain radiates on the shoulder and then along the upper limb, mainly in the ulnar territory. Some patients complain about pain radiating also to the axilla and the lateral part of the thoracic wall. And in a few patients, pain started to radiate also on the pectoral area. And in some cases, because it was the starting symptom, and this is especially in men, it was mistook for cardiac pathology. Very few patients also may present a radiation to the ipsilateral hemiphase and nape. And in these patients, you may actually find even an ulnar sign, which, by the way, immediately disappeared after the surgical decompression. Now, pain is also associated with sensory disturbances, and paresthesias typically run along the ulnar nerve territory, although in some cases there might be an involvement of the last 3 digits, and occasionally it might be the whole of the end, but this was really uncommon. Algoparesthesias typically worsen at nighttime, and when the patient is performing repetitive movements or carrying weights, or for instance, in actions that require a prolonged shoulder abduction. These actions always trigger worsening of algoparesthesias in these patients. Now, Stefano in his presentation already mentioned something about neurological assessment, and he mentioned provocative tests. And we know that in medical books you can find several tests that are applied in cases with thoracic outlet syndrome. Now, Hudson test is actually something that can be positive also in patients that are asymptomatic. So I would not consider that part of the assessment. The other tests are not as reliable. And personally, and I think with Stefano, we are going to be in agreement on that for sure. The assessment is based on what I call the TOS triad, which is Rus test, traction test, and Tinal sign. So the Rus test that I also perform together with the patient, in my opinion, is actually the less reliable of the 3 provocative tests I mentioned before. In my experience, I think probably the traction test is more significant, but definitely the thing that is really the key in the neurological assessment is the presence of a supraclavicular Tinel sign. Diagnostic assessment, in my experience, is something that should always hinge on imaging, MRI of the cervical spine, and MRI of the brachial plexus. I never go for surgery unless I have imaged the patient both on the cervical spine and the brachial plexus. And if you see the discrepancy between the patients that underwent the MRI of the cervical spine and the MRI of the brachial plexus, none of the patient was operated before MRI of the brachial plexus. And the difference is unfortunately related to the fact that I work in private institutions and sometimes I'm not able to get the insurance cover for the investigation. I also completed the assessment with the EMG and nerve conduction study, and I'm going to explain why later on. So MRI of the cervical spine is essential because we need to be sure that this is not an discogenic pathology. MRI of the cervical spine is usually completely unremarkable, or there might be findings which are not consistent with the clinical presentation. But all the patients I operated on present one element in common, which is the fact that they all have a complete loss of the cervical lordosis, which is an expression of the muscle imbalance. Electrodiagnostic tests are always done. They are always unremarkable if there are no neurological deficits, but they are useful because you might actually have the association of thoracic outlet syndrome with other entrapments. And this is certainly a condition that has to be detected. But in my experience, the core of the assessment is the dynamic MRI study of the brachial plexus that I perform because it rules out the possibility of other pathologies of the brachial plexus, and it should provide evidence of thoracic outlet syndrome. So with my friend Sandeep Buratoki, that is presently working in India now, we have tried to study the biomechanics of shoulder abduction related to the possible onset of compression on the neurovascular bundle. And we eventually developed a protocol for a dynamic MRI of the brachial plexus in these cases, which encompasses a brachial plexus neurography that focuses on the scalene triangle, on the costoclavicular space, and the retropectoralis space. And what we do is that we study the patient in neutral position and then in shoulder abduction, and then we make a comparison between the 3 sides that I mentioned before. And among the findings which are considered significant, the main thing is a narrowing of the costoclavicular space in the that is more than 50%. So when we have evidence of this kind of finding in arm abduction, we consider that this might be consistent of a compression on the neurovascular bundle and therefore thoracic outlet syndrome. Now, the idea of the dynamic brachial plexus is related to the fact that, as I said before, this is in my opinion, a dynamic entrapment. So the MRI should try to reproduce the situations that you have in real life. But of course, you have no gravity when you perform the MRI, and this may expose you to have false negatives. I tried to do the MRI in the upright position, but it's not feasible. I started testing myself, but for patients that present symptoms, it's impossible to keep it. It's a long study, and there might be quite a lot of movement artifacts even in the normal MRI. Now, I consider the possibility of false negatives. So if the clinical presentation, in particular, the presence of a DOS triad is really suggestive of thoracic outlet syndrome, I would go for surgery anyway in these cases, even if the MRI does not show remarkable findings. And in 2 of these cases, I found a neurovascular conflict because the patient presented an accessory cervical transverse artery that was running between the middle trunk and the lower trunk and was likely to cause the symptoms. So the important findings in my experience is that if you have a positive DOS triad, which means if you have Rust test, traction, and Tinel, which are positive, and the dynamic MRI shows compression on the neurovascular bundle, this is really a confirmation of the diagnosis. And you can see that this is statistically significant in our experience. And on the other side, the cases that were ruled out to be thoracic outlet syndrome presented a further confirmation of that, because whenever we explored the patient physically and we found a negative Tinel on neurological assessment, the MRI was generally unremarkable. So we have a very strict correlation between the 2 things. So in conclusion, I would highlight once more that this is a dynamic compression. I would like to further proceed and trying to understand whether there might be really a gender-related etiology. The supraclavicular Tinel, in my opinion, is the most significant provocative test. And based on our experience, I would say that the DOS triad and the dynamic MRI do represent the most accurate workup in this kind of cases. I'd like to say thank you for your attention, mentioning that yesterday for this country, for the UAE, it was a great day because HOPE probe that was launched from Japan reached the red planet, and this represents the first Arab country that manages to reach the planet Mars. So thank you.
Thank you, Deborah. Excellent presentation, like always. We have a comment from our colleague Mikhailo Tatarchuk. Many thanks for great presentation. In Ukraine, we are finishing thoracic outlet surgery with chronic invasive electrostimulation system NACI-3M for 6 months. What do you think about chronic electrical stimulation? The question for all. And most often, and another question is, we can first comment from this and then go for the another one. If you have the question in the question and answers down, if you want to see.
I think you can use chronic electrostimulation if you have a failure for whatever reason, and but I wouldn't put it in every case, even if it is an expense. I would make it only in failures when there is some doubt of a disputed, and then when your surgery has found probably nothing, and the symptoms are more like a regional complex type syndrome.
And we have another comment, like most neurophysiology says, as it as sensory motor polyneuropathy. What sine qua non shall be in neurophysiology to clinical diagnostics trend of thoracic outlet syndrome?
Can I comment on this?
Yes, of course, Christian, and you raise your hand.
Yes, so for the electrodiagnostics, I think one of the key features that I want to see is the cutaneous antebrachial medial nerve, the nerve conduction velocity, because this will rule out what is a lot of times misinterpreted for ulnar nerve involvement, but it's not, because it's not an ulnar nerve. It's usually a very proximal branch of the plexus. So this is a very easy way, and I want to have it bilaterally to compare, one with the other. And I think this is one of the, and of course, we encounter a lot of changes in both ulnar and median, but also in the distal radial nerve innervated. So the CH5 is going for radial nerve muscles. So I think that electrodiagnostics have a huge importance in diagnosing. And to add something for diagnose, so I'm a big fan of ultrasound. So I agree with Deborah that if you have somebody that can do this kind of MR neurography, and at least in Germany, we don't have a lot of places where we can send these patients to. And I think one of the big changes recently is that we can diagnose now TOS. It's not a rule out diagnose. I think you can see the pathology. And in our experience, and I think Nora will agree, because she has a very, we have the two experts, in the German experts in ultrasound for plexus close by. And they can easily and very clearly depict the underlying pathology. And this is including both anatomical and both vascular changes. So I think the main advantage of having now diagnosis or diagnostic tools, that you really can rule out this pathology and that you can tell what it is. So it's not only it's TOS or not, or it's something else. You can say, okay, this is the fiber, this is an accessory muscle, this is a thrombosis, this is whatever. And the main advantage of ultrasound is, it's very dynamic, and you can put the patient in whatever situation or posture the patient will have the pain in. So I think this is the main advantage. So I really want to push forward the idea of ultrasound in thoracic outlet.
Thank you, Christian. This answers the last two questions from the Q&A section, as well as the chat, where people were asking on the experience of ultrasound. So I think that does matter on experience of the person who performs the ultrasound. And I'm kind of jealous, Deborah, you have very nice MRIs, very good work. So this is something I always try to reach with my radiologists. So very, very nice. So I think we have a great overview now on anatomy, diagnostics, and classification. But I think the real question is, we have diagnosed everything. When do we indicate surgery? And I think Alan helps us with a case where we can think together about when to perform surgery in TOS patients.
Okay, so first of all, thank you very much for inviting me to participate. It's a thrill to work with the Europeans and so on. It really is a thrill. So thank you very much. And I've already learned a lot just listening to the first few presentations. So it really is good. What I'm going to do is I'm going to take you through a case, and this is a patient who I had to manage. I've got a tremendous panel, so there's a tremendous amount of knowledge sitting there on those Zooms. So I'm going to be looking for help in managing this case as we go through it. So our panelists, this is meant to be very interactive. So please chime in at any time. I'll begin with what I always have to begin with here in the United States. I understand you guys don't have to say anything, but I have no disclosures. So I'll start with that. I will say that thoracic outlet fits in with everything else we see in peripheral nerve, which is pain problems. And we do have to manage these patients. We have to come up with a good way to manage them because it's just not fair to leave them in pain. Okay, so I'm going to take you through a case. This is the presentation, exactly how it presented. 24-year-old female. She is a right-handed nurse, works here at Johns Hopkins. She was lifting a patient and developed pain later that evening. She describes the pain as radiating from the neck region around the shoulder, and it goes down the shoulder, right-sided, to the front of the chest, indeed, down into the scapula as well, then down the arm, predominantly to the ulnar aspect of the hand, but not a clear ulnar distribution. She noted that her pain was clearly made worse when she would try to work with her arms up over her head, and she would get some relief by having her arm down by her side. She's very, very benign in terms of a past medical history and surgical history, has been really healthy all of her life. She came to the Johns Hopkins healthcare employees about 4 days after the onset of this. They called my clinic and said, can we send one of our nurses over to your clinic to take a look at this patient and see what you think? So we said, of course, be happy to see her. So she came over to the clinic and we did a physical exam on her. So I've heard already in our presentation certain things that I better make sure I have on my physical exam, given what we've already heard are very important maneuvers to look at. So I'm going to go through. She did in fact have quite a bit of tenderness. She had tenderness in the supraclavicular fossa, tenderness in the infraclavicular over the pec minor. We can talk about the maneuvers, whether or not you really feel that we should be doing those maneuvers. And more importantly, I'm going to put up some pictures. We can discuss just what those maneuvers are. We throw around these names, Adson's, Ruse, and so on. And I can tell you that different people use them different ways. Even when you look at the papers, they're quite different. So I'm going to leave Adson's and Ruse alone for a second and just say where the tenderness was. She had a very strong Tinel's on percussion of only the supraclavicular region. Percussing there produced a tingling down her arm, nothing at the cubital tunnel, nothing at the carpal tunnel, and nothing in the infraclavicular region. So that's her basic history and physical. In terms of these maneuvers, Adson's and Ruse, this is from the vascular paper, actually, the Vascular Society, which I think put out a really, really good review paper if you're interested in looking at TOS. And they really have done away with the Ruse and the Adson's and so on, saying that they're really not that important and they're probably not accurate and so on. So they describe two different types of tests. One is the elevated arm stress test, which is like an Adson's. Basically, in the patient we saw, that was very provocative. I'll also say that not only was it provocative, but her radial pulse basically went almost to zero when she abducted and externally rotated. But I'll also mention that happened on both sides, and she's only symptomatic on her right side, but definitely a vascular compromise when she goes into the abducted position. This is the upper limb stress test. People think this will help differentiate a cervical radiculopathy. So it's supposed to be done to help rule out if you have an acute radiculopathy versus thoracic outlet syndrome. I will say that her test for this was negative. So her provocative maneuver was abduction, external rotation, and doing a stress test did not bring on symptoms. Again, she felt much better with the arm by the side, much worse with the arm abducted and externally rotated. So that's her history physical examination. She's now about 5 or 6 days into this, and she's miserable. Have I got enough on my history and physical? Are there other things I have to do on my history and physical? Are there other investigations I need to do? Thoughts from my panel?
Hello, can you hear me? This is Eric Zager.
Yep, hear you fine, Eric.
Hi, nice to see all of you, and great program. Congratulations to the organizers. Thank you so much for inviting me. Well, Alan, I must say, I almost never see acute presentations of thoracic outlet syndrome. I only think of this as a chronic condition. And I think you were very kind to agree to see this person immediately in your clinic as an acute injury just a few days prior. But a couple of red flags. Number one, it's a work-related injury. And I don't know if this applies as much for the rest of the world, but at least in North America, that's a red flag for thoracic outlet. Now, that's not to say that you should not take these people seriously. That means I use too many negatives in that sentence, but in other words, take the patient seriously, but keep that in mind, because I think thoracic outlet syndrome is one of the leading candidates for an abuse of our insurance system, along with low back pain and neck pain and all sorts of other work-related and injury-related presentations. So that's just keep it in mind. I don't think you have enough, in short, to diagnose this. In terms of your history and your exam alone, you mentioned tenderness, both supra and infraclavicular. I check these people for tenderness everywhere. I'll tap over their clavicle. I'll tap on their trapezius. I'll feel their paraspinous muscles. And if everything hurts, that's another red flag. Someone earlier mentioned fibromyalgia and chronic fatigue syndrome. And a lot of these vague syndromes, unfortunately, overlap with thoracic outlet presentations. So another thing to be cautious about is if there's diffuse tenderness, that's a patient I'm putting in a little bit of a separate category from a classic neurogenic thoracic outlet. This is more in the category of the disputed painful syndrome. I think that's something else to keep in mind. You mentioned, Alan, that you consider this EAST or elevated arm stress test to be more like an Adson's. I basically ignore the Adson maneuver because the changes in the pulse are so common in the general population that I don't even pay attention to that. And as you know, especially as neurosurgeons, we're not going to see many true vascular cases of TOS because these are rare and they tend to be emergencies with emboli if it's arterial or thrombosed vessel. An acute presentation of a Paget von Schroeder is a swollen blue arm. It's not a subtle presentation. So we're generally dealing with pain, and is this, truly a pain from the thoracic outlet region, or is it some other site of pathology? So in terms of other maneuvers to do in your exam, you've got to look for the common things like cervical spondylosis. So you've got to check for a Sperling sign, see if there's something that points you in the direction of the cervical spine. The other speakers mentioned that you have to investigate the cervical spine and other potential entrapment sites before you conclude that it's thoracic outlet syndrome. So I would like to be as optimistic as Christian Heinen when he said that this is a diagnosis you can make with imaging studies. I'm sure in Germany you can do that, but my imaging is hit or miss, quite honestly. Most of the imaging studies I get are outside studies that are not really true neurography studies. And so it's very difficult for me to conclude from the studies that this is a patient who's an operative candidate or they're not an operative candidate. I'm closer to, I think, Deborah's approach and maybe Stefano, that this is mainly a clinical diagnosis. And I do try to get neurography done. I always get ultrasound done with various maneuvers. But for me, it's more of a overall clinical picture to make the diagnosis.
Do I send her away? Do I send her to physical therapy? Do I say to her, this is probably thoracic outlet, and just let's stick with non-operative care for now, and I'll see you again in a couple of months? Or do I say I am going to investigate, even though we're only a week into this at most? Is it still time to do MRI, ultrasound, Dopplers, EMGs, whatever you want to, whatever your flavor du jour is? She has a normal neurological exam. As I said, she has no other findings. She has bilateral positive in terms of loss of pulse.
Yeah.
Is there anything else I have to do at this point, or can I send her away? Panel?
Go ahead.
Stefano, you're muted.
My
I didn't.
something.
Turn your microphone, Stefano.
Yes. Do you study it anatomically? Nothing. You didn't find anything, an old sequelae fracture, because it could be also that an effort unleashed, triggered the initial syndrome, although all seems to be a disputed case. But if you don't have abnormalities, I think this is a disputed case, and that you have only to decide whether to go to surgery or not, or wait.
Haven't done any investigations yet. Again, she's a week into this, and I'm seeing her, so I haven't ruled out anything else in terms of doing investigations. I've only done a history and physical exam, and the question to you is, with that history and physical exam a week into it, is it even warranted to do an MRI or an ultrasound or any other investigations at this time, or do you wait?
Why not at this time?
Deborah?
There were a few things I would like to say. I think you mentioned that she had a sudden onset of pain that was also radiating to the pectoral area, correct?
Yes.
Okay, so, and Eric said thoracic outlet syndrome is usually a progressive onset of pain. Now, this is what I believed until I saw two patients, as I mentioned in my presentation, that were two men, by the way, that started exactly with acute onset of pain in the pectoral area that was also associated with brachialgia. And these patients ended up in the emergency department and were investigated for cardiac pathology. So they had onset, which was acute. And the only cases I have with an acute onset are those presenting the pain radiating to the pectoral area. I don't know why. I am not able to figure out the explanation for that, but this is my presentation, my experience. And then, well, I mean, I would not say that we can rule out other pathologies in these cases, but some of the symptoms, I mean, I would say they are kind of rather suggestive for a thoracic outlet syndrome. And anyway, okay, she has been in pain for 1 week, but I definitely at least would start imaging her with an MRI of the cervical spine.
We have another raised hand by our dear friend Ridvan Ali Mehmeti from Tirana, Albania. Ridvan, please.
Yeah, thank you. What rings the bell to me about this case is a possibility of myofascial pain and the top band of the scalene muscles, something like what Bob Gervin teaches us. We have also to consider that in a case of acute onset of pain with heavy weight lifting, you know, you may have also an interesting area of the scalene, anterior scalene and the middle scalene, and you have an irradiation of the pain that may be to the upper part of the thorax.
Mm-hmm.
Probably.
All right. Thank you. In the interest of time, I want to keep moving. So I got to tell you, I sent her for physical therapy. I sent her away and said, come back in a week or two. If you're still symptomatic, I'm hoping this will all go away. She came back in a week or two. She was still symptomatic. So let's see. At that point, it was investigation time. And I had to decide, am I doing ultrasounds, MRIs, CT Dopplers, EMG, anterior scaling blocks? I happened, because of access to what I have here, I did an ultrasound. The ultrasound was read as normal. We did an MRI of the brachial plexus and cervical spine. Both were also read out as normal. I did a Doppler study because she did have changes in the arms. The Doppler was very abnormal, but it was symmetric in the two arms. EMG was considered, but given her absolutely normal neurological exam, I held off on an EMG because there was no tunnels at the ulnar nerve or at the carpal tunnel. and I considered whether to do a diagnostic anterior scalene block. This is popular in the literature, and I'll throw it out to the panel. I have a patient with a normal neurological exam, symptoms suggestive of thoracic outlet syndrome, completely normal exam. I have no positive findings. At this point, is it appropriate to do an anterior scalene block, and am I going to learn anything from doing it?
Alan?
Do anterior scalene blocks.
Yeah, I don't do them personally, but I do send them to my ultrasonographer to do ultrasound guided scalene blocks or interscalene triangle blocks. And we're reviewing our last few years of doing these blocks. And I can tell you that they have been completely unhelpful in terms of diagnosis and prediction of how people are going to do with surgical intervention. So I'm still gathering information to see if these are helpful to me at all. There is literature that suggests that it should be helpful in management, but my experience has been completely disappointing. And so I'm wondering whether I should continue doing them or not. I'm interested in the rest of the panel's experience, but my experience has been very disappointing.
Ridvan, do you want to comment?
In the view of the possibility of a top bend in the scalene, anterior scalene muscle, the block in this case should help. At least if you have a negative response, it means that you'll not think of it anymore, and you'll not send it to Bob Gervin. But in the meantime, if you have a positive anterior scalene, you have a topical neurological diagnosis.
Okay, so I sent the patient for a diagnostic anterior scalene block. That was positive. She got excellent pain relief for the duration of the block. I don't know what it means, but I will say that it was a positive block, meaning that she gets good pain relief when she had her anterior scalene block. She actually had it done a second time. The pain physician who did her block said, "We'll come back, we'll try it a second time." She came back, they tried it a second time. She again got good relief, but it was for a very limited amount of time. Okay, so at this point, I made the diagnosis of a neurogenic TOS. I think it is the disputed form. She has an absolutely normal neurological exam. The question is, now what am I going to do in terms of treating her? She had a positive anterior scalene block. All other investigations have been absolutely normal. Her physical exam is absolutely normal. I think we can go with physical therapy, but my question to you is, how long can I send her for physical therapy? What is a reasonable physical therapy course? I sent her and she returned at 6 weeks, having undergone physical therapy for 6 weeks, and said, I get a little bit of relief while I'm getting the physical therapy, but then the pain comes back. At this point, do I continue with physical therapy? It's now been 6 weeks. We're basically 2 months into this. Or do I keep going with physical therapy? What is reasonable? Panel, when do I say it's enough, or do I keep going with physical therapy?
Yes, Alan, I make sure that my clinic schedule is busy for at least 2 or 3 months after the first appointment. So I give these people plenty of time to think about it and to try other things besides surgery. I make surgery my last choice. And I also ask them on more than one occasion, is this pain so disabling that you cannot live with it? Because we could always do an exploratory surgical procedure, which in my experience would have probably about a 50 or 60% success rate, a little better than a placebo response. Because sometimes the imaging, again, in my experience, maybe not in Germany, but in my experience, it's not so good that I might find something at surgery that would be helpful. So I ask really carefully how disabling are the symptoms? Can you live with it? And I describe the surgical options, obviously, and tell them what I would do if surgery is elected. But I also reassure them that this does not tend to become a crippling condition. This is not MS. This is not ALS. This is not something that's going to wind up with a useless arm. So they have to recognize that surgery really should be a last resort only if their symptoms are disabling, and then I would consider it. But 6 weeks for me is very early. I don't think I've ever recommended it after such a short time course.
Okay, so she did get her 6-week course of physical therapy. She got a number of anterior scaling blocks. She comes back. And as Eric said, I did wait, and I made her wait a long time. She comes back, she's now 3 months. She's been out of work since the onset of this. It's been 3 months. She's tried physical therapy for 3 months, repeated scaling blocks, including the Botox. Again, the imaging studies have been normal. She did try acupuncture, by the way, which gave her very good pain relief, but very transient pain relief, much like she said with the physical therapy. So it's now 3 months. I've got nothing more than a history that is suggestive of the disputed form of thoracic outlet, completely normal physical exam and neurological exam, normal imaging studies. She's 24 years old. She works here in my hospital. What do I do with her?
Does she have any non-somatic baby causes? I mean, we know that a lot of TOS patients, maybe because they undergo a long story, but maybe due to their character, they sometimes present with, you know, some kind of, well, not really somatic causes for their pain. Is there any history of that?
I'm just a dumb neurosurgeon, so I'm not sure I know how to truly investigate that. But as far as I can tell, she's a reasonable person, and she didn't seem to have any comorbidities that were concerning or behavioral issues that were concerning. But I'm 3 months into this with no better explanation. And she's been out of work, you know, nursing here for 3 months with her pain. And as Dr. Zager said, it's not debilitating. She's not dying with pain, but she can't work, and it's been 3 months. She wants to get back to nursing. So would anyone offer surgery? Would anyone say to me it's crazy to offer surgery?
Deborah, turn on your microphone. Turn on your microphone.
I wanted to say I do not have any experience at all with the blocks, but concerning physiotherapy, when I decide the option treatment for my patients, something that I consider is the average clinical history. In other words, if the patient comes to me after years and years that she has been in pain, I just give indication for surgery. Like a lot of the patients I operated here in the UAE, they had been suffering for years, as I said, as an average, even 5 years or longer. In that case, if we consider that, again, it's a dynamic compression related to a muscle imbalance, the muscle imbalance built up through many years, and physiotherapy is not going to be able to, re-educate the patient to a good ergonomic position. For those patients where the onset of symptoms has a short history, like in this case, I would go for physical therapy at least for 3 months, unless the pain is so severe that it's actually really disrupting the quality of life of the patient. So in my opinion, for this case, Alan, I would offer her surgery, to be honest. And when you say that the MRI of the plexus was unremarkable, was it just a normal MRI or was it a dynamic MRI?
So excellent question, thank you. So the way we do our MRIs on these patients is we do them it's a dynamic MRI. They get their shoulders down by their side, and then they get it with both arms up over their head. We call it the Superman position, because they're like flying with their arms over their head. We do it in both positions, the MRI, and we do a comparison. And quite frankly, this is MR neurography. We have not found it to be terribly helpful in the disputed form of MRI. We're not getting it, or disputed form of TOS. We've not been able to get a consistent abnormality on the patients, but we're still working on that with some machine learning. But that aside, you're right. We've waited 3 months on this patient. She's had a lot of physical therapy. Her pain is not truly debilitating, but it is preventing her from nursing. So she indeed said, look, I've had enough of this and I want to, explore surgical options. So I want to get back to my nursing. The physical therapy people, I phoned them and asked them how's it going, and they said, we can keep going, it's not a problem. But she wanted to start exploring surgical options. So what I'm going to do is I'm going to hold off there. We're going to hear about surgery from some of our presentations, and then I'm going to continue the case as to what happened.
Alan, great, thank you. Great case. I think we already summed up somewhat the roundtable discussion on what conservative management can be done. Great. We have a question. One is, I recommend a psychological consultation. Did you think about that?
Indeed, that's a really good, I agree with you. When we have these kinds of patients, we often will involve our psychology, our pain psychologists. And in this particular case, we did recommend it. And much like Eric said, it's rare for me to see a patient this early. Usually we see them, as Deborah says, months or years into their presentation. This literally was within a week. And I just wasn't used to dealing with the acute situation. So I did ask one of our pain psychologists to get involved with the patient and try to help her deal with being out of work. And they raised no red flags in terms of the patient.
And also the question of time when to intervene came up from Deborah. And I think there is data that if we intervene after 2 years, then the outcome is worse. So there is a reason, if this might be a surgical case, to not wait too long. So I think it's a great case for discussion. Thank you, Alan. And I think that's now the point where we go to surgical options. And we are very happy that Shimon, with huge experience in publications on thoracic outlet syndrome, is on to report for us his view and his experience on rib-in surgery.
Yes,
Shimon. Greetings to Tel Aviv.
Thank you, Laura. It's okay?
A little louder, maybe? Yeah.
Yeah. Okay. Objective of this presentation is evaluated. This study evaluated the effectiveness of supraclavicular approach for microsurgical neurovascular decompression in the treatment of thoracic outlet syndrome without rib resection. Theoretical background: the pathomechanism of thoracic outlet included more than one site of compression, each increasing the influence of other, causing of multiple crash phenomena. This theory explains the need for extensive neurolysis rather than routine approach we are based on the compression of a specific anatomical structure, for example, ribs or scalenus muscle. Clinical acceptance in this group was physical. In this study was 21 patients. 21 patients is 71 for men who underwent primary thoracic outlet surgery without rib resections. Age of the patient from 16 to 40 years. And this is an important point. Elapsed time since beginning of the symptom range from 1.2 to 15 years. Practically, most of the patients have long history of the problem. And this is pure study for 21 patients. Of course, we have additional patients with recurrent thoracic outlet who underwent surgery in other hospitals, and one patient who underwent surgery with its cervical rib resection. This patient were excluded from study. All patients underwent standard investigation. Practically, most of the patients, provocative manner was always positive. And a very important point of view in evaluation is ultrasound observation of this patient. This is example of a ultrasound of one of the patient, and very especially this during the patient as he move his upper extremity, what happened? Look, what we see in ultrasound. This is a regular ultrasound, and this is schematic ultrasound, same places. we start ultrasound, patient start to open his hand. Look, this is going to be fibrous tissue between muscle. This is compressive science of the brachial plexus. So it's very clear picture. Going back that you will be see this. It's normal situation. During the movement of the patient upper extremity, you see is scar tissue or fibrous band between muscle. Preoperative follow-up is very important, especially patient, we don't operate patient minimum at 8 months or more, or 1.5, 2 years for follow-up. And this old patient was monitoring priority surgery 1.2 years, but it was observed minimum 3 times during this period, because I think clinical picture is most important in diagnosis of thoracic outlet syndrome, and must be symptoms in this patient, and complaints was consistent in nature. Conservative treatment, medication, physiotherapy, hydrotherapy, swimming was without improvement, and patient also have strong motivation to return to normal everyday activity. This is patient underwent surgery using supraclavicular approach with partial scalenectomy, trunk neurolysis, and release of subclavian artery. The trunk of brachial plexus was dissected, underwent neurolysis, and very gently retracted in order to expose the fast strip and the transverse process of C7. The firm fibrous bands between fast or cervical rib and the brachial plexus elements generally was found and removed. During the surgery, we always use neurophysiological responses. This is electrophysiological response during the neurolysis of the lower trunk. This is before neurolysis of the lower trunk, and this is after neurolysis, increasing of a response, positive response after release of the upper trunk. Practically, electrophysiological response was positive in 83 operated patients. Surgery. Our preference is usually to avoid fast cervical rib resection, as the offering fibrous bands much more often as the relevant pathological structures, and the fast cervical ribs does not contact or distort the plexus in most of the cases. With intensive neurolysis, with the intensive release of the area, practically we have a lower trunk free, and also subclavian artery free. Post-operative follow-up of the patient was from 22 to 48 months. We have 1 patient recurrence rate. This means 4.7% results. Pain relief. A patient was divided for 3 groups: mild, moderate, severe. 16 patients from 21 response, a very good response for surgery. For moderate response was 3.6 to 6. 4 patients, it's been 20 patients from 21, and only 1 patient suffered from the pain. What is important for us is physical, more important than neurologically, it was important physical activity. What is normal life of these patients? And we investigate different parameters. Physical activity before and after surgery. Patient who was operated, everyone have any kind of restriction. Any patients is active movement was found before surgery. After surgery, 81% of the patients have no restriction in the everyday activity. Limited restriction was in 40% of the patient, and greatly limited without success in 1 patient. This is patient have underwent thoracic outlet syndrome. Employment. This was one of the more important, because I completely agree with Eric. This is problematic patient. It's really problematic patient. It's part of the patient is enjoy from social support, etc. As employment of this patient in follow-up 24-48 months, for fully employed patients before surgery was 24%. After surgery, it's increased to 81%. Partially employed was 52%, after surgery only 14%, and unemployed 5 patients and decreased to 1. In conclusion, the supraclavicular microsurgical approach provides a convenient and wide view of the brachial plexus and minimizes the risk of neurovascular damage. Allows extensive neurolysis, removal of adhesion, scar tissue, and fibrous bandages, followed by nerve and vascular decompression. Therefore, prevents fast cervical representation in most of the cases. A detailed description of the different neurosurgical or surgical techniques for thoracic outlet was described in the review with Eric Zager in the Schwittek operative neurosurgical technique. Thank you very much.
Congratulations, Shimon. Thank you for this presentation. Any question, comments? From the panelists or for the panelists?
Lucas?
Yes, Christian, please.
So I think in comparison with other compression neuropathies, the TOS is a real 3D one. So I don't know how you deal with it, but I agree with Eric. By the way, of course, in Germany we have excellent ultrasound, but we also care for clinics. So what I wanted to say is that the main investigation tool during surgery is, at least to me, is the finger or the dissector. So I put the arm so that I can move it. It's not under the drapes. It's open. I can move it and bring it to the position that the patient prior to surgery tells me where the main pain appears. So I will put the arm during surgery into this painful position and palpate what structures will impede or will somehow harm the plexus. So I don't know how, this is of course not scientific, and this is, nothing that you can measure, but this is for me in choosing the radicality of resection. So if to take a bone or a muscle or whatever, this is a key feature of intraoperative assessment.
I completely agree with you. Of course, with this finger, we investigate. Sorry. Okay. Lower trunk was free, and subclavian artery was free, and we investigate this finger. If it was free, it's no any problem, of course. And I not exclude cervical rib, but it's only in extreme cases, not like routine procedures. That's all. Because what you have finally after cervical rib, first of all, we will have today a presentation about this, but the classical vascular approach is good approach for cervical rib, but not, you don't have possibility to good exploration of the brachial plexus. One, and problem of the thoracic outlet is not exactly pressure from the ribs. In scar tissue or film bandages that surrounding lower trunk and in artery. Practically in all cases, I found it's like one body, subclavian artery and lower trunk. It was closed. No any possibility free to move. It's necessary to release, very carefully release, millimeter after millimeter, all these bandages, all this fibrous tissue. And only after this, for completely release, we investigate distance, possibility, free movement, and this was enough. And in long-term follow-up in this patient, it was positive for this study. Also, be afraid we have in other surgeries, we have few patients after cervical rejection. This was many scar tissue in area, and also a hypertrophic scar is results of the previous rib resection, hypertrophic bone scar.
I have a question to Shimon. You said in extreme cases, which are the extreme cases? What you consider an extreme case to do a first rib resection? When you have a failure, when you have an abnormality, and this is not really a first rib resection. If it is not normal, it is another thing, because we are talking about normal first rib resection. There are people who say that to do a thoracic outlet surgery, you must remove a normal first rib. I do not understand why, but I want to know from you if you have extreme cases where you decided to do this.
Extreme cases is mean is it will be found not because neurological picture, it was during the surgical findings. It's mean ribs was like here, is severe compression of the artery or lower trunk. Of course, you can use a diamond drill, but unfortunately, in case of recurrence, we have one of the cases of the release, partial release of the ribs with drill, is will be back again. Because in this patients with severe compression by the rib, I think removal of the cervical of S rib is necessary.
So it is a very,
yeah, exactly.
narrow angle, a very acute angle rib.
Exactly. It was only intraoperative findings. For this reason, always in all thoracic outlet syndrome, my colleague, a vascular surgeon, also preserve for standby or necessity to do together something. All surgery we doing together with vascular surgeon.
Shimon, thank you very much. There's one question from the audience. One is, what was the average time to surgery? There's a person who understood it was 1.2 years. And then it differed into longer time frames. And another comment that some cases do have 30% of psychological abnormality, and that this might be a cause of surgical failure. So the decision for surgeries should be very strict due to the participant.
A timing of surgery 2.5 hours generally. It's admitted time in 2 days. Why 2 days? Only because for next day we're doing X-ray of the lung to be sure that no problems with the pneumothorax or something. And this is timing of surgery. Is because the supraclavicular approach, we don't have any problem, not with bleeding, with nothing. It's pure approach for brachial plexus, the neurosurgical approach, and today I know that most of our colleagues using this approach for treatment of thoracic outlet syndrome. This is first question. Second question, sorry.
The second question was the time when intervention should be performed.
2.5 hours.
No, the time too, not the time, the longevity of the intervention, but the time it takes until you take a patient to surgery. So there are some cases in your cohort that may have a very long time with symptoms.
We present only surgical cases, not many cases, small groups, only 20, 21 patients and so. But generally, experience is more than 50 patients. More than 60, 70% of the patients improve or significantly improve with conservative treatment. This is one of the reasons that we wait with surgery. And this is one of the reasons that 3 times before surgery, patient was observed, because time to time is psychological or something. It must be consistent to complaints. It's very important. The same surgeon will be observed with a patient few times and finally decide conservative or not conservative. Also, possibility of conservative treatment today show it's really give possibility for many patients to improve without surgical procedure. I prefer to wait minimum 1 year, also if patients suffer.
You have kind of an average cutoff of 1 year, what you intuitively think might be.
But you have some cases which were waited a longer period for the surgery.
Yes, of course. It also 2 years, but not more. Generally, it's between approximately 1 year.
But the question or remark here in the chat is maybe a misunderstanding that some 15 years mentioned in your presentation about waiting for the surgery or something like that, or maybe it was misunderstanding or maybe miswritten.
Yes, it's a good question, but you know, my country is a very small country. It's not many specialists for thoracic outlet syndrome. If patient will have problem after 5 or 7 years, he will be call me or will be back to outpatient clinic again. Finally, after a couple of years, I don't hear about this patient.
Alan, please.
Excuse me, I wonder whether there is clinical reason to put off the patients. There are only two possibilities: or you don't believe in diagnosis, or you think that they will heal by themselves, like in lumbar disc. Why you put off surgery in lumbar disc? Because there is no surgical hernia, or because you think they heal. So if you put off patient, they don't heal, probably. And it means that we are not sure of the diagnosis. Otherwise, why putting off patients? I mean, deliberately, not because we have a long waiting list.
I don't think he was deliberately putting them off. I think there's a delay in the patient getting to him for surgery. I think that's more of the reason. So in terms of, I just wanted to agree with a couple of statements quickly. We found that it's very important to put the patient through all of the maneuvers during surgery. So we pre-drape the arm, and we do put the patient in all the different positions and postures before we close, because there are a number of times where I've done more surgery based on finding things that were tight when we went into a different posture. That's one. Two, in terms of first rib resection, a standard first rib resection. Indeed, a lot of our vascular colleagues, that is the standard procedure. It's a first rib resection is the primary procedure, even for the disputed neurogenic TOS. But I can tell you in our institution, when they do the first rib transaxillary, now they're also putting the arm through the various procedures, even after their first rib resection, to make sure they've taken everything down. There's a question about endoscopic. Some people have tried endoscopic supraclavicular approaches. Just to let you know, I have 2 patients now that I've done brachial plexus repairs on who had an endoscopic approach to their brachial plexus. So it is good for business if people are going to start doing endoscopics. I've also got cases now where they're doing thoracoscopic first ribs. So people are using the Da Vinci robot now to take out the first rib. And actually that's a very slick procedure because you do get a magnificent view. So I'll just say that I've seen that now. I haven't personally done it. I've done Da Vinci for tumors, but I would actually look at it. It's a beautiful view to use a Da Vinci for a first rib thoracoscopically. Thanks.
Thank you. Deborah, you want to say something?
I wanted to say something because it has been mentioned quite a few times that patients with thoracic outlet syndrome may present psychological problems in a remarkable percentage of cases. So I must be very lucky because my patients have no psychological issues. My patients are people that were in pain, that they wanted to sort out the situation, and they did well once the diagnosis and we did the surgery. There's something that I would like to emphasize. When we say that a patient has psychological issues, it's because we have not been able to understand what they have. And if we consider what it means for a patient to live in pain for days, I mean, around the clock, months and years with pain, because I personally think that if I had to live in that condition, I would develop psychological issues. So, I mean, I think we should be a little bit careful when we talk about psychological issues, because if the patient has a short clinical history, okay, then I can understand that. If a patient comes to you, like in some cases, being in pain for years, I mean, when your quality of life is disrupted, who wouldn't develop some problems? So are we really not sure that what triggered the psychological issue is pain? It's not pain. I don't know if I made my point clear, but I mean, let's be a little bit careful before we talk about psychological issues when we are the ones that do not know exactly what to do. Because as I say, I don't get the experience that we have so many, difficult cases.
I think
it was just a little remark I wanted to do. That's it.
That you don't know what's the hen, what is the egg.
Exactly. This is what I say. I mean, as doctors, it's very easy to stay, you know, behind the desk and listen to the patients talking about pain. But I mean, do we really know what it means to be in pain for days, for weeks, for months? Because in my experience, for instance, my modest experience, I had an herniated cervical disc, okay? And I remember I've been in pain for several months because I didn't want, for several weeks, sorry, because, and unfortunately I sorted out. It was not so easy. I mean, after 1 month of being constantly in pain, day and night, and not being able to sleep, I mean, really, probably this is the way I am because I also have psychological issues, who knows?
I think
She didn't want me to operate. This was the reason.
Yeah, you see, so.
Yeah. Nora, we should move on. We have a few questions in the chat and Q&A, but we will discuss them later. I think we should move on. Now it's 10 minutes to 7.
let's do it.
Okay.
As it already came up, there are some strong opinions on rib out in transaxillary approaches. And I think it does make sense to go a little bit in the literature. We had the great opportunity to listen to so much experience. And when you look it up in the literature, you will find an argument for anything in thoracic outlet. So you can do anything and you can cite always someone who wrote it. But if we try to think about evidence, then things get a little bit, the air gets thinner, let's say so. So there is only one prospective RCT in TOS. And you can see here very nicely why it is difficult to interpret that, because there are 55 patients, it's a single center study, and it's the study of supraclavicular neuroplasty without a rib resection versus the transaxillary rib resection. And it's somewhat in disputed TOS as vascular pathology as well as patients with weakness were excluded. This study showed that this, the transaxillary rib resection was better than the supraclavicular neuroplasty without rib resection. But again, it is single center, it's a selection of patients. And can we really draw any conclusions to argument for a transaxillary rib resection in disputed TOS patients? Moreover, the supraclavicular neuroplasty, this is what it is called there, but I think it describes somewhat the main approach that every one of us is favoring, the one from supraclavicular without too strong opinion on taking out the rib, so leave the rib in when possible. So this is the approach which was compared to here. Again, only 55 patients, but there has been some recent literature from the vascular community, and I think the American College of Surgeons Quality Improvement Program database serves as a nice data source for some analysis. You can see here that at least the numbers in these publications were higher, of about 1,431, and the second one from another group in 1,853. So a substantial amount of patients that were analyzed, but the questions were different. So one of the analyses went on first or cervical rib resection, and they showed the documents on nerve injury, major bleeding, and readmission rates. This is what was part of the database. They had a part where the trained nurse can click on nerve injury, so below 1%. We don't know if this is good or bad. If we have 100%, in 100 patients, we have one patient, or in 200 patients, we have one patient who has a nerve injury. Is that okay? Is that good quality of the intervention? And in this analysis, they compared rib resection versus without rib resection. They also had low numbers of nerve injury, but they had a little bit longer times in the rib resection group versus the non-resection group. But again, there is no quality of outcome available in these study cohorts. The data is based on a 30-day analysis after the intervention, and it's performed by a trained nurse. And again, they did not do any analysis on the approach. So did they come from supraclavicular or transaxillary? So in my opinion, we cannot really answer the question, which is the best approach for thoracic outlet on an evidence-based way on this data. But when we go in the tremendous literature, there are just some examples why to argument for a rib resection. So there is a reduction of recurrence in repeat surgeries, and due to the data that I just presented on the slide before, there is a low complication rate. But the contra is, there were some studies that did not show any additional benefit by the cervical rib resection, and the cervical rib resection did result in significant longer hospital stays and longer operative time in one study recently published in Hand. And if you look at these operative times, this is severe, this is a significant difference in operative times, and some of the other studies shows that operative time, longer operative time also results in worse outcomes. So there might be some collinearities in these findings. So if we think about pro and contra for or against transaxillary, the pro for transaxillary is that the incision is not seen on the neck. I think this is something which is for transaxillary. It is an easily described access to the rib. So you see the rib coming up in front. There are authors that report that they can easily perform a scalenectomy via this approach. Contra is you don't have any, let's say, proximal control on the nervous structures. You may have a reduced visibilities of on fibrous bands. So Stefano very nicely showed that there is a variety of bands that can be present. And you have higher rates of pneumothoraces. This is nicely shown. The personal experience, which is just my experience, is I do have a very active vascular surgeon around here, which is using the transaxillary approach. And I personally see some patients with severe complications after these transaxillary rib resections. So there's some scarring. In some cases, there is a brachial plexus lesion. There are pneumothoraces, and I also have seen sympathetic trunk lesions. So in general, if you only look into the literature, you have to take into account that to the current day, we don't have any real evidence on that matter. There's a Cochrane analysis on this, but this is only including the trial that I mentioned on the first slide. We do have heterogeneous definitions of the syndrome, and we also do have very, very heterogeneous study designs concerning patient inclusion, concerning surgical management, and so on. They are usually single center studies with small numbers, and possibly, this is something that I can only assume, but possibly there might be a publication bias regarding complications of the interventions. My personal experience says that the transaxillary rib resection is not without risks. So this is the one I personally do not prefer. And I think some of, or most of the panelists may agree. But I want to bring you some cases, two short cases, no complex ones, regarding the anatomy, but I want to point out one thing. So this is a very young female patient. She has pain and sensory loss in arm elevation on the right. It's the lower trunk affected. And you can see here that her quality of life regarding motor function, ability in daily livings, anxiety, and so on is severely impaired, mostly in these anxiety and daily living things. And she has a reduced overall health in her subjective perception. So 100 is the full score, and she's a little bit reduced with 83. And you can see here the pictures. We do have a neurography on the right-hand side. This is not the quality I usually get. So to say to Eric that in Germany we have very, very bad MRIs too. But this is a nice one, at least this is what I think. And what I'd also always do is a CT in arm abduction. So the MRI here was performed in non-function, but we do a CT also with CTA in arm abduction to know a little bit about the bony anatomy around here, to have an idea about bony abnormalities, but this one is not a real bony abnormality. It's just the first rib coming, and you can see the clavicle here. And in that patient, you can see that the rib is above the clavicle. And this is what I experience in some patients, some of the typical type that already were described by Deborah. Sometimes the first rib is a little bit above or significantly above the clavicle. And you can see here that this might be a reason why the inferior trunk, especially the T1 nerve root, has an elongation and mechanical trouble. So what we did in her, we came from supraclavicular, we did the neurolysis, we visualized artery and vein, we did a partial sclerectomy, we did nice decompression of everything so that we can gently, and I know that this has to be done very, very carefully here for the nervous structures. If you have to go to the rib, you have to be careful with it. So we do intraoperative neuromonitoring with free-run EMG just to get warnings, and you have to be very aggressive with the neurolysis and decompression before, but then you can nicely visualize the first rib. This one is seen here below. Here's the phrenic, here's the anterior scalene, and here you can see it from below. And it was relatively easy in that anatomy to take out the rib from supraclavicular. She had a very nice recovery of her symptoms. Her quality of life did improve, and also her overall impression of her personal health. And this is in contrast to another patient who's a 56-year-old, who's male, who is a little bit higher BMI, and not such a long neck. And there we did also the CT. You did not see any troubles with the artery in that case, but you see that the clavicle is at the level from or above the first rib, and there is no trouble here in that case. So we did only decompression and neurolysis of the plexus, artery, and vein. We did find a very, very significant fibrous, a classic fibrous band. This was resected. We went out. We did not have to remove the rib. Good recovery in terms of quality of life, and he had a severe impairment of his peripheral health, which improved dramatically after surgery. So my personal conclusions are that a heterogeneous disease also needs heterogeneous treatment concept, that this might be the reason why clear evidence cannot always help, because it's just so heterogeneous. In our clinic, we do MRI of the thoracic outlet. Quality is not always as good as the one I showed. We also do cervical spine imaging. We do an EMG. We also look for the cutanous antebrachiomedialis nerve. We do ultrasound with duplex, and we do a CTA and arm elevation for two reasons: to rule out if there's any vascular troubles that we may run into, and to also see what the relation is of the first rib to the rest of the bony thoracic outlet. And we prefer the supraclavicular clavicular approach. We have kind of an intraoperative pathology checklist. So we check for the tight scalenal jab, see if there's any Simpson fascia processes, rib, bony compression, anything, or even a first rib. We take the finger technique that has already been mentioned. Just to have a kind of rescue solution. Some surgeons, if they see that they have or think they have to resect the first rib from the supraclavicular way, they do some kind of an extension of the incision below the clavicle. If this is not easily performed from above, then you also can do this below the clavicle. The transaxillary, in my experience, we do not perform this on a regular basis. And my personal experience from referrals from other clinics is that I might say stay away from it like the devil from the Holy Grail, but I think there's Professor Shinara who might tell us now that transaxillary is the solution for the syndrome. So thank you.
Thank you, Nora. Excellent presentation. Any other comment, question?
Yes, may I a question? Nora, I've seen in the papers you analyzed together cervical rib resection and first thoracic rib. They are not the same thing.
I know.
Because first thoracic, it means rib cage, means what nature gave us, whether one, well, the first is an atypical rib because it is more narrow, what you want, but still is part of the cage. And then, and is below the thoracic outlet. C7 shouldn't have a rib. And in this case, I think it can be removed because it can be the source of many concerns. I think we should concentrate on first rib. This is the question, because if C7 has a rib, this in many cases can and should be removed because it is a source of concern.
You cannot draw this from the publication in all cases
I mean, I would have rejected from the beginning this publication because there are two different things.
Any other comment, question? Eric, what about your opinion regarding all this?
Sorry. Well, that was a great talk, Nora, as expected. I agree in general that it's very rare for me to think about taking out the first rib from the supraclavicular approach. I just don't like pulling on the trunks of the plexus that much to get out the rib. I have done it, and it was not a pleasant day. So I avoid it. Cervical rib, as Stefano said, is a different story, and I have taken those out, even an elongated C7 transverse process without being a full cervical rib. I've taken it out if I find at surgery that there's some distortion or compression of the lower trunk, or even the middle trunk on occasion. The transaxillary approach I don't do. I have some good vascular surgeons who do that procedure, but they don't do it often for neurogenic thoracic outlet. They save it only for the vascular cases. In fact, just 2 weekends ago, I got a bad phone call from one of the vascular surgeons who had done a supraclavicular approach for repair of a subclavian artery pseudoaneurysm. This is a true rare arterial case. And during the exposure, there was a prominent cervical rib with a pseudarthrosis to the first thoracic rib. While taking out the pseudarthrosis and this prominent bony exostosis, the lower trunk was injured. And they recognized it at surgery. They did a repair as best they could, and then completed the vascular bypass. But the patient woke up with a very weak hand. I recommended imaging immediately afterwards just to make sure there was no hematoma. There was, in fact, a small hematoma. We explored it together, took the hematoma out, which I don't think was the problem, and inspected the lower trunk, but there was really nothing more to do. In fact, after this conference, I'm going to see that patient for a post-op follow-up this afternoon, but I'm very worried that that hand is going to be permanently injured. So first rib resection can be hazardous. I think it's requires more excessive retraction of the plexus elements than I'm comfortable doing through a supraclavicular approach in general. But I think it's a viable procedure, certainly for the transaxillary approach. And there are a lot of publications with reportedly good results. Of course, these are surgeons reporting their own results with transaxillary first rib resection for neurogenic thoracic outlet as well as vascular. So I don't think we really know the answer to it, but my preference is similar to Nora's. I prefer a neurolysis. I do a fairly thorough anterior scalenectomy. I'll divide fibrous bands as I find them in the middle scalene as well. I always look for a scalenus minimus, because I think that can be also a problem. Simpson's fascia, the suprapleural membrane, I look for on every case, because that can also be a problem. But I don't take out the first rib through the supraclavicular approach. That's my bias.
Thank you, Eric. Any other comment, question? Well, if not, we should move on with the presentation of Dr. Chinara. Then we can come back to the case to discuss with question and answers regarding interesting case that Alan presented.
Well, hello, everybody. First, I'd like to introduce myself since I'm a guest here as a vascular surgeon, the only one here. I work at the clinic, which is the cradle of the vascular surgery at Balkans. We are doing a lot of open surgery still and endovascular too. Among the other procedures, we also deal with the TOS. I'd like to start the lecture with this old picture presenting how does it looks when you take off the collarbone. So it's very obvious. It's a small space, and there you can meet not only the nerve structures, but also the arterial and the vein trunk. So it is very common that anything that disrupts this can cause the thoracic outlet syndrome, whatever it is, a physical trauma, frequent injuries, anatomical defects, and the other things that cause this. The symptoms are very close to the symptoms that you have described, but there is a slight difference because we have two kinds of these symptoms referring to what kind of a problem do you have. Is it a vascular TOS or is it arterial? So there is a discoloration of hand. There is the arm, which is in pain and swelling, possibly to the blood clots. And it's not rare thing that you meet the blood clots inside the veins and arteries. And also the lack of color, weak or no pulse in the affected arm, cold fingers, hands and arms. And there is a fatigue arm during activity. Of course, there's the other sensation that you have described, I won't mention, but you can see in these pictures in the left corner, there is a venous toss, and you can see the difference. There is the cyanotic coloration, there are the collaterals, and there is a picture of the phlebothrombosis developed on the field of the thoracic outlet syndrome. But on the contrary, when you have the arterial problem, there you have the pale arms, and there is sometimes atrophic ulcer on the top of the fingers or even gangrene. So what are the possible causes? Cervical rib is the most often the cause, but it is also possible to find fibrous band connecting spine to the rib. Also the poor posture, for example, dropping shoulders, or if you lean your head forwards, that all the vascular surgeons do. I am afraid I'm going to suffer that in days to come. And of course, trauma or some frequent activities, normal activities or activities connected to the sport, on pressure of the joint due to heavy weight, and of course, during the pregnancy, joints are getting loose, and that could cause the similar problem. We have a lot of diagnostic things to do, but the fact is that these patients come too late to us, and we have late stages. But GPs always sometimes can come to conclusion and they watch the X-ray that there is extra rib on the neck, or do the ultrasound, which appears to be showing thrombosis in the vein or arterial system, and then send to the vascular surgeon. We do more invasive tests, for example, the angiogram, which shows there is a stop when you lift your hands, or if you perform NMR or the CT, then you can see the problem in the arterial tree, possible aneurysm with the thrombus inside, or you do angiography, and then you can see that there is a problem on the vein, just in the projection of the collarbone. So you can do all these tests and you do the same thing, but there is one thing I would like to emphasize, and I haven't heard that any one of you have mentioned, and that is the blood test, because the thrombophilic states very often go with this problem. And it is a very great problem if you don't take care of this, whole the procedure of treatment could go wrong. So what are the possible complications if you don't treat this patient? And those are the patient that comes to me because somehow they are kind of in the late states of this disease. They have the permanent swelling and pain, blood clot probably, and pulmonary embolism that connected to this state, ischemic ulcer in the top of the fingers, and even the gangrene, not to mention neurologic complication that I've spoken today. If you talk about the venous TOS treatment, then the first thing you should think is thrombolytic medication. After that, anticoagulant medication, and the surgery is the last option for this problem. So if you do have a problem with the venous system, you can insist on conservative treatment, but most of these cases have deterioration, the symptoms are persisting, and high dysfunction. The first idea is to do thrombolytic therapy with catheter-guided thrombolysis in first 14 days. And after that, or before that, you can do thromboaspiration in one of these modern systems. If you are successful to establish the lumina of the vein, the second thing you should think of is there any external compression? If there is a compression, then you should do additional venography. And if you prove that, then you should go for surgery. And the first one of the procedure is the first rib resection. I admit I've never done this, or I've seen that anyone has. But if they're talking about the TRUST treatment, the surgery is the first choice. The removal of the extra rib or the first rib, just in purpose to make enough space for the arterial system. Of course, the medication that comes later can accomplish the treatment, but there is a case which is very certainly treatable only by surgery. So you can see here, there is a extra rib, and it's proved by the angiography that the artery has been pressed by the bone structures. You can see here very nicely two bones pressing the artery, and the artery is widened. There is the aneurysm in the distal part. And really, and if you look carefully, there is the rib, there is the subclavian artery, which is pressured, and this further part of the artery, there is the aneurysm. And this is probably the best picture illustrating the whole problem. This is the first rib, and this is the cervical rib. They even have the joints here, and this is the collarbone. And all this space been very much shrinked by these structures, and no wonder that the artery suffered. We usually use the supraclavicular approach. Very rarely we go transaxillary, and we do that for the extra rib through axillary approach. We do the first rib, but very rarely, because we have some different reasons for that. The problems with the arterioles are different than the nerves. We don't need that extensive approach very often, very rarely. So the first thing you should do when you see this aneurysm is to resect it. When you open up the aneurysmal sac, you can see that there is a thrombus, and the form of this thrombus is very unusual. You can see that the blood flow could wash away this thrombus, and the main problem in this situation is that you get a distal embolization of the arterial tree. The fact is that these patients are very often coming lately, and they have already had a sort of ischemia of the hand, and these procedures are most often lymph-salvage procedures. They are not the patient in the early phase of the disease. So after that, you should also do the resection of the rim band, and if you accomplish the bypass, then you provide the patency of the drug by removing the string. Of course, there is a problem sometimes when you do all this and reconstruct the arterial tree, that the distal problem still remains because of this thrombus, so we have to do some additional bypasses. Anyway, some of these patients, when they come, have to be told that if anything that you do is successful, that does not guarantee that the arm is going to be safe. So this is the problem that you are already heard that I've told you the embolus have practically stopped the blood flow to the distal parts, not only the arterial tree, but even this part where the deep profound brachial artery origins, and it is a very important artery for the arm. If it's a patent, the arm can stand even if the distal arteries are occluded. So this is the problem in vascular surgery. And the fact is these patients are coming too late to us, and only 10 to 20% of patients with the TOS need surgical treatment, but most of the patients with the venous or arterial TOS need surgical treatment. What's more, the facts are very encouraging when we come to the surgery for the venous TOS and also for the arterial TOS, but more frequent are the operations on the arterial tree due to aneurysm. There are some open questions because the point of the vascular surgery is different from the neurosurgeons. For example, the constant pressure on the arterial tree causes the development of the aneurysm. The aneurysm itself has a inflammation nature, and it is normal that the neighborhood structures are also involved with the process. We now don't know, because we vascular surgeons focus only on the vascular structures and the neurosurgeons only on the nerves, how this affects the neighborhood nerves. Is this indication for neurosurgeons to take part in such operation or not? And how to deal with this early stage patients? That's another open question, because when they reach vascular surgeon, most of the process have already been done, and the patient is coming as an urgent patient, not an elective patient, and all these procedures are mostly being salvage procedures. So it seems that conclusion of this is that the vascular surgeons and neurosurgeons have many things in common when they discuss about the thoracic outlet syndrome, but they very rarely operate together. We have heard a colleague that is describing that the vascular surgeons have called in to help him when they have collision with the nervous structures during the first rib resection transaxillary. It's normal, but the other way, vice versa, is also normal to vascular surgeon take part in neurosurgical operations. I think that could be a conclusion of this, my lecture.
Thank you so much.
Okay.
Great. Very good conclusion.
Any comment, question? Eric, please.
Just a comment. That was an excellent overview of the vascular problem. I have to say, I have seen a fair number of patients who have presented with a, mostly these are venous thoracic outlet cases acutely. They're managed by the vascular surgeon with thrombolytics and anticoagulation, and then eventually first rib resection. The vascular surgeon is happy, but the patient's not happy because they still have a pain syndrome. And I'm curious from the panel what to do with these people, because they have a pain syndrome that resembles probably one of these painful neurogenic presentations or a disputed form, but maybe some of it is still a residual of their vascular thrombosis. These were all acute subclavian vein thromboses and swollen arm, and they are revascularized, but their arm still gets a little swollen. They still have some dilated veins on their chest and their upper arm, and they have pain. So is that a patient we should be thinking about surgery to decompress their thoracic outlet further? Do they need more than just their first rib resection? Do they need a neurolysis? I have explored a few of these patients, but I'm not really sure if it's the right thing to do. obviously we put them through all the usual conservative measures and we investigate them with imaging, et cetera, and send them for physical therapy, et cetera, but they keep coming back with pain. Is that a case that we should be thinking about surgery for? That's my question to the panel.
Good question.
Eric, sorry.
Please.
Yes. Yeah.
Okay. If I may say, I totally agree with the colleague. Every thrombosis leaves some consequences if it's the arm thrombosis or leg thrombosis, and probably the nerves are also suffering. And this is a state that lasts for a longer period of time. That's why these patients have to take anticoagulant medicines for a longer period of time. It takes 3 to 6 months for collaterals to develop to make a proper venous drainage. And probably the nerves are suffering. And that's exactly what I was talking about, that the vascular surgeons and neurosurgeons should be together in this problem, not only when the complication comes, but perhaps to plan the operation together. I've never heard the peripheral nerve because I'm very often seeing these nerves operating with Professor Vasilis, but probably it would be better for the patient if the neurosurgeon make neurolysis while I prepare the artery and repair the artery. So that I think that is the good idea.
I have 2 patients suffered from a vascular problem. This patient was treated, underwent thrombectomy, and continued to suffer from neurological deficit and pain a long period of time. It's been more than 6 months. One was a doctor of gynecologist lady, and second was army soldier. I operated these 2 patients exactly with supraclavicular approach without removal of it, but intensive neurolysis. This patient dramatically improved neurologically, but this was not acute cases of vascular compression.
Any other comments?
So maybe one thing again to come up with the German ultrasound. So if you want to if you want to differentiate, of course, the post-thrombotic syndrome, which is a residual of the stenosis, the vascular troubles, you want to find out whether there is a scarring here by the procedure. I have seen that. Or if there is residual compression in the supraclavicular space, which probably was not addressed by the transaxillary or other approaches. So if time is a good thing to wait to see if everything resolves, but possibly you can perform an ultrasound to see if there's any scarring. If there's still a mechanic issue, you can possibly think about a revision. You, of course, always want to avoid a vision. I think there we are with Alan, who probably tells us now how long he waited in his case. And I think waiting in revision cases is even more sound. But this might be an option to have an additional argument for the patient. Hey, Alan.
Want to hear what happened?
To the second part.
Second part.
To the second part. Everyone wants to know what happened or what's going to happen.
Well, let's see where we're at. Okay. So we said it's time to consider surgery. The patient, again, is 24 years old. She's 4 months into this, has failed non-operative care, has classic disputed form TOS. We've not found any other causes, and she'd like to consider surgery. So on the table is a neuroplasty from above, a first rib from above with neuroplasty, a first rib from below with transaxillary. Do we have any recommendations, strong recommendations, that one is better than the other? Okay, I don't think anyone, after listening to our talks, we've already heard that the literature is very iffy on this. I'm at Hopkins where that paper, the only randomized study was done. I was part of that study. So that study did show that transaxillary first rib was a little bit better. But I can tell you, having participated in that study, there were a lot of issues with the study. In any case, well, here's what happened. Her father happens to be a surgeon, and he's down in Texas. So he said to her, there's only one way to treat this because he's been asking his buddies. And so she decided to have the one way to treat it. So she went down to Texas, and she had a first rib resection done transaxillary by a vascular surgeon. She got 2 months of moderate relief. Now, she was able to get back to nursing, even with her only moderate relief. But after 2 months of moderate relief and then back to nursing, she lasted about 2 months on the floor. Pain was back and said she can't nurse anymore. So she comes back to see me at that point and says, I know they did the vascular, first rib from below and so on and so forth, but you need to help me. I can't work again. Pains come back. What should I do? So we're now about almost a year into this. She's off nursing again. She had done well transiently with a first rib, and she now wants to have a supraclavicular decompression because that was probably what she should have had. So she says, after reading all the literature, is it reasonable to go ahead and do a supraclavicular at this point or not?
Yeah.
Thoughts?
Yes, it is.
So
Yeah,
Stefano,
go ahead.
Stefano says yes. Eric, what was it?
Yes, it is.
Yeah.
I think unless she doesn't want to spend all the money with a psychologist, yes.
Okay, so I don't want to drag it out too long. So I went ahead and did a supraclavicular neuroplasty. She got 2 months again of moderate relief. Not quite as good relief as she got the first time with the transaxillary, I'll say. But she did get moderate relief and got back to nursing. She goes back to nursing. She's there about another 2 to 3 months, comes back to see me and says, it's different. Now it hurts a little bit differently. Still going down my arm. And it's true, when I examine her, not so much supraclavicular, she now has a very strong Tinel's infraclavicular. So I look at this and I go, dang, is this one of these pec minor things? I image her, the imaging looks fine, just some scar tissue from her previous surgeries. Clear Tinel's on percussion on the infraclavicular, less so on the supraclavicular. The question becomes, and I discuss it with all of my colleagues, do I now take her and do a pec minor release from an infraclavicular? Thoughts?
Alan, this is usually a patient you've already sent to me for another opinion.
It's funny you should say that because we're going to get to that.
And I'm suffering along with you. So, yeah.
You're right.
My experience with the pec minor syndrome is I've never been impressed with the findings. I have explored a few patients. I've never been convinced, even with the Tinel's, and the imaging for me has always been normal. I've explored a few. It takes 20 minutes to do. It's easy, but I'm not convinced I've ever helped anyone with that.
Anyone suggested it's a bad thing to do?
No, not bad. Probably unuseful, but not bad. Now you have started the game, you have to go on.
So Stefano, you're exactly right. Okay, so I did a pec minor takedown. And again, I got about 2 months of decent relief, not great relief, but this time she's still not getting back to nursing. So we are now about just under 2 years out from this. She had transiently got back to nursing now and again. She still has classic symptoms of neurogenic thoracic outlet, the disputed form. I sent her back for physical therapy a couple of times, and it keeps coming back the same thing. As long as she's doing the physical therapy, she gets transient relief. Otherwise, it goes, the pain comes right back as soon as she stops. Still gets a little bit of relief with acupuncture, but very transient. Her EMG gets repeated. It's absolutely normal. There's no evidence of radiculopathy or of peripheral nerve entrapment. And she is miserable. This is where Zager comes in. This is where I send her for other opinions usually. And they either go up the road to Zager, they go down the road to Alan Levy at Miami, they go out west to see Spinner at the Mayo or Susan McKinnon out in WashU, and I usually try to share the grief here. So I did try to share the grief on this one. I sent her out to the Mayo. Mayo said, nothing to do at this point, can't help her. Anyone have thoughts, last ditch efforts for her?
We all have patients like this, unfortunately. And I think we have to admit that there are some patients we just can't help with surgery. You know, you've done all your due diligence with your psychological profile and so forth to make sure it's not the patient in her head, but sometimes more surgery is not the answer. I think it was reasonable to do all these things because you did exclude conservative management quite thoroughly. So you didn't hurt her at least, but you just didn't help her. You could try a stimulator, you know, but
epidural.
But I'm not
epidural with the steam wave, and then it is all what you can do.
So we considered neuromodulation. That was going to be the next thing we were going to consider.
Yeah,
was use of either peripheral nerve stimulation or
just to finish the circle.
Okay, so we were considering her for spinal cord stimulation, and while we were setting that up, she did see, oddly enough, she got another opinion from my retired mentor. So the person who wrote the paper that Nora quoted, the only randomized study, the senior author on that, James Campbell, who I trained under, that's who I did my fellowship with and so on. She ended up seeing him for an opinion because he's an ex-Hopkins person and so on. He provided her an opinion, called me and said, here's what I want you to do and here's why. And I went, you gotta be shitting me. You gotta be kidding. Okay. So I did a repeat, yet another operation with a supraclavicular neuroplasty, something, and she's basically cured. What's the question marks?
Sympathectomy.
Sympathectomy was a good thought, but no, but you're right. That would have been something Campbell would have been all over. So think about it. And I'll tell you where he came up with this, is he said to me, show me all of her imaging. I want to see all of the pre-op, post-op, everything imaging. So Campbell went over all of the imaging. And the one thing that I had not taken into account is that on her very first operation, which is the one that did give her really the best relief, albeit transient, her first rib resection had a 2.5 inch remaining first rib. Campbell said, go back and take out the rest of that rib and she'll do just fine. I went back for that fourth operation, took out the rest of the first rib, right to the start of the first rib, and she was cured. So, interesting case.
It's a good lesson, actually, because it's quite common, and maybe our vascular colleague can comment on that. It's quite common to have remnants of the rib left behind because it's tough to get all the way to the extremes of the rib and to disarticulate it.
You don't have to disarticulate.
But it carries risk.
Yeah, you don't have to disarticulate. And some of the literature, if you go through it carefully, says that basically you can leave 1 to 2 centimeters of rib. But if you leave more than 2 centimeters of proximal rib, you haven't done a first rib resection. And in this case where there was really, it was more like probably about 4 to 4.5 centimeters left. When I went back and took that, it seemed to have made all the difference. And it was not easy to do, I got to tell you. But it seemed to make all the difference. And she's been fine ever since.
That's instructive. I think obviously that you counseled her that a third operation or fourth operation, whatever it was, fourth operation was higher risk because of the scar tissue. So that's where you can really hurt somebody. But having said that, not every exploration that someone else does is the same. And so I have gone back in when someone had good relief from their initial surgery, but then recurrent identical pain. And I've found that there's a remnant of anterior scalene that is scarred to the plexus. And if you can safely get that off the plexus, you can help these people. Unfortunately, scar tissue tends to grow back. And so we haven't yet figured out a way to block that. I do tend to leave in some anti-scarring agent like Ceprafilm or Sergi Wrap, but I'm not at all sure that that really does anything to prevent scarring. But sometimes you can help people even with a 4th operation, but the odds are against it. You were lucky.
I was very lucky. But I was also wrong in not following up, and Campbell was absolutely right. I should have done the imaging and understood that there was a fair amount of residual first rib.
I kind of just assumed that you would have done your due diligence before she went to see Jim Campbell.
It was embarrassing.
Yeah.
Any other comment, question? Christian?
So I remember that my first head of department, Hans-Peter Richter, he went to David Klein in New Orleans. And when he came back, he introduced the posterior approach for the recurrent task, especially for this cause, to get to the remnant bony parts and to be safely not going through the whole scarred plexus again, and to really get targeted to the bone without touching the nerve. And this was an impressive procedure. I think there are some colleagues that modified this in a very, I think, very nice way with using tubes and not cutting all the muscles. So I have no personal experience with that, but that was, you know, the patients, the few patients that were treated with this, they had a relief. And I remember Menezi talking about this going back into the scarred plexus, and we all know he was fond of gliding tissues. So his approach was to create a gliding flap, taking, for example, from the pectoral space, so the fascia in between pec major and pec minor, and to wrap it around the preoperated plexus to enable gliding without you know, being tangled in the scar. So, well, but this was not 100% success too, he admitted.
So it's still fairly morbid coming from the back. You still have to cut muscle. It's a beauty. You get a magnificent exposure, but it's at a cost. And so the flip side of that is, once again, I would check with your thoracic surgeons. For me now, having worked with a thoracic surgeon using the thoracoscopic approach, especially with the Da Vinci, you get a tremendous exposure thoracoscopically, and you can do the same thing. You can get to that first rib very proximal with the Da Vinci and do a great resection with very little morbidity that way. So it's, you know, a variety of different approaches. I think if you want to take advantage of that, just work with a thoracic surgeon who does thoracoscopic approaches, and you'll be amazed at the beautiful approach they can give you.
Any other comments?
Eric, you're muted if you're talking.
Eric, so turn your microphone, yeah.
Yeah, so I'm sorry, I agree that the posterior subscapular approach does give a beautiful view of the lower trunk of the plexus. So for tumors, I think that's a beautiful approach, but it is very morbid to cut all that muscle, and rehab afterwards is prolonged and difficult, and there are risks. So I don't use that for recurrent TOS. I find that too morbid. But I guess it's with a less invasive approach, which has been described recently, I think that's worth considering. But it's deep. It's a deep approach.
There are a few comments and questions on the chat. For example, have you given a root block? Generally, opinion for the root blocks in this thoracic outlet syndrome cases. Then another one from Carlos Rodriguez. Did you use any kind of medication acting as a central nervous system modulator of pain in the course of disease? This is regarding this refractory cases with pain. And
we always use medications.
Let's finish one by one. Come on, who would like to comment?
So we always try medications. And so in this patient, for example, she was tried with a typical CNS suppressant. So she would have been on, we usually go with gabapentin first. And if that doesn't work, we'll use pregabalin. Pregabalin's a little more expensive. So we try gabapentin first. And usually we'll work with the pain group, who will do a combination of medications. So I'll do any kind of medication trial to keep them away from me having to do multiple surgeries. Because I agree with everybody, once you get into multiple surgeries, your results just plummet. So absolutely, medication trials, usually with the expertise of a pain practitioner who's very familiar with putting together medications, is done here.
Interesting comment appears in the chat that thoracic outlet cases with muscle atrophy and pain syndrome after scalenotomy or first rib removal in Ukraine, they put on nerve electric systems MESI 3M for chronic invasive stimulation. You see this question in the chat, I believe. Who'd like to comment this? Any experience with that?
In general, pain syndromes of the brachial plexus after radiation, or in severe cases, neuromodulation, of course, is an option. But I think in the thoracic outlet, if we think there has been no harm to the plexus during surgery, and scarring or mechanical complications might be the issue, we'd probably go Alan's way and try for fourth surgeries. Direct surgeries, but neuromodulation at some parts comes up, I think. But luckily, most of the results were kind of good that were reported in the round when I get things right.
Any other comments?
Yeah, I'm very excited. I'm very excited. I want to hear Ridvan's case.
Yes.
I'll go quickly through the slides to show you the case of a young lady who was operated in our institution in 2012. She was 18 years of age when she came to our clinic. She had she was a left-handed hairdresser, complaining from progressive fatigue and incapacity to keep comb and hair dry along this 1.5 years, which was her main complaint. And in the meantime, she explained that as a child, she had an underdeveloped right hand, which prevented her from writing with the right hand, which is the first hand used here in Albania for writing, but she was a left-handed through her childhood. And this was her appearance. So she had a smaller right hand with intrinsic muscles of the hand, hypertrophied, and incapacity of moving and doing all the fine movements of the fingers of the right hand. So the first thing she had was an X-ray which showed this bony exponent, which is a 7th cervical rib on the right side, which was followed by angiography. By that time, I always discussed cases with neuroradiologists, and they were eager to perform an AG for me and for the patient, of course. And what we see is this is the position with the arm adducted, and this is the abducted arm, and you can see the defect of feeling the subclavian artery with the abduction, which of course was consistent with the erased arm test positive. And we decided to do a supraclavicular approach in this case. And what we saw was, this is the primary upper trunk, and all these other structures were mixed together. We started to show, to explore what is in here, but as you can see, it is a pulsating tissue that we go through. We found a transversa colli artery, which was compressing over the other medial primary trunk, which was released by dividing, ligation and division of this small artery. And the subclavian artery was just underneath the middle primary trunk. Opening these two structures, we found the small part or portion of the inferior primary trunk. And we continue to remove the scalene muscle in order to have more space for the artery to be decompressed. And this is the situation by the end of the surgery. And we see that still we have these two structures, the scalene, the supraclavicular artery and the inferior primary trunk all together. This is the upper primary trunk, this is the middle primary trunk, and this inflamed structure is the inferior primary trunk. And this is the subclavian artery attached all together with the inferior primary trunk. So we went on and divided these two structures, and under the subclavian artery, we found the tip of the cervical rib, which started moving with the C-cell, with the carousel. This is the cervical rib removed, and the structures of the plexus, brachial plexus, that are divided, and you can see here the C-cell removal, piecemeal removal. These are all the pieces together. It's quite a long cervical rib, and by the end of surgery, you can see the three primary trunks, upper, middle, and lower, and the subclavian artery, which are now free. You have here the remnant of the anterior scalene and the happy neighborhood between the primary, inferior primary trunk and the subclavian artery. So this is what we usually do in these cases, and we try to do, as neurosurgeons, less damage possible to these other structures, but enough, we open enough space for the neurological structures to be released and not compressed, or do not have the offense of the pulsation of an artery, because we are very much aware of the neurovascular conflict. So when I was younger, I mean 9 years ago, I used to do it by myself, but rather now I would invite my vascular surgeon to be with me, you know, and to have a chat and to do the case together. But the young lady is still in good health, because she used to bring some bottle of wine by the end of the year. And she is back to her hairdressing profession. So what I wanted to say with this case is that you do not pretend to have a regain of the muscles of an atrophic, underdeveloped hand in a case like this, but you can remove and you can return to the previous life person who is having recent symptoms. So this is my conclusion, and my thanks for the attention.
Thank you, Ridvan. Excellent presentation, excellent case. Any comment? Vincenzo, please.
Hi, I wanted to ask to Ritman, did you perform only the X-rays and the vascular sequences? So you did not perform any MRI? For
No,
hair?
by that time, we didn't have the luxury to do all kind of examinations on the, and it was quite clear, you know, in the presence of a cervical rib with a vascular competition and obstruction. What else you should need, you know?
Well, then actually I would take the chance and ask the panelists, especially Deborah, because of her presentation regarding the discussion we had about MRI and the cost of MRI. Do you always perform the MRI, or why you don't have the possibility for pacemaker, for claustrophobia, for costs, to perform also a CT scan with angio sequences? And do they have the same efficacy? Is there somebody who does not perform routinely MRI and does CT angio?
Well, most probably nowadays, the neuroradiologist will go first for the angio-CT, which will give you an idea also of the intima of the vessel.
Sure.
But also it is less invasive for the patients. But you can also have a DSA if you are lucky to have a neuroradiologist do it for you still.
Crescenzo?
Mm-hmm.
I do think that before you go for these cases, imaging should always be completed. I mean,
I also think so.
During these sessions, actually, we have seen a couple of cases, one presented by Stefano and the other one presented by Helen, where not re-imaging the patient or imaging the patient in the first place actually was the reason why there was like a mismanagement somehow. So for me, I have to say, right now, I certainly would not go for surgery unless I have an MRI of the brachial plexus. I agree that the second option might be the one that you mentioned. But yeah, and maybe, I don't know, I don't have experience with ultrasound, but I would say that, yes, I mean, nowadays, I think MRI in cases should be a must. I mean, we make MRIs for so many cases and
Yeah,
for
definitely.
stuff. And I mean, somebody comes for low back pain and maybe they have a little bit of sciatic pain and you easily get an MRI. And when you have to perform these kind of procedures, we are here discussing whether we should do the imaging or not. I mean, for me, we definitely have to consider to go for MRI.
Yeah, I totally agree. The question was about in the cases in which you cannot perform MRI, like, as I told you, insurance reasons or like claustrophobia, or I don't know, some issues with the patient, or you are in a peripheral place in which you cannot run it.
Claustrophobia should not really be something that gets along the way, because I mean, you can sort it out somehow. So this is something I would rule out. Okay, so basically the problem might be insurance cover. And okay, and I'm concerned about that because, as you could see, I had problems like that. But if I need to prove if I need to do the surgery, then usually, I mean, if you bargain a lot with the insurance, sooner or later I get it. And talking about pacemakers, so we have to consider that right now we have the new generation pacemakers, which allow you to do MRI even in patients that have a pacemaker. So, I mean, and then we also have to consider that really this must be, you know, the worst luck ever. With thoracic outlet syndrome that is not insurance covered, and it's also the pacemaker. I mean, it's overlapping of to say so in Italian, you understand? Okay, bad luck.
Deborah's lab for lumbar pain is well known and resists over the centuries, I think.
Yeah, exactly. Yeah, I haven't changed it even in the Middle East. Yeah.
Can I make just one other comment about that? We have been doing MRIs for patients with pacemakers for at least 10 years, but always with a cardiologist present. And there are some rare patients who are completely pacemaker dependent who cannot get an MRI, but the vast majority, if you have a cardiologist present to monitor them, they can turn off the pacemaker, monitor their heart during the procedure, and then turn it back on. But I'm sure Christian will agree with this. You can certainly image the plexus very well in various positions of the arm and the neck with ultrasound. And I think that's a very good alternative if you can't get a good MRI scan done. But I agree, in general, I image all of these people with MRI and ultrasound, brachial plexus and cervical spine.
Yeah.
Any other comment?
Oh, Lucas, 3 hours on thoracic outlet syndrome.
Medusa of the peripheral surgery, what to say? I mean,
beast or beauty?
Yeah.
And see how many participants. I wonder why in the congresses we have always empty rooms. So we have 200 people. Probably the virus is stimulating thoracic outlet. We should conclude this.
At the moment, there were 233 participants, and something around 50 people, more or less, on YouTube. So we are around 300 people in this webinar. I mean, numbers are changing, but comments are very remarkable, and we receive many congratulations. Eric, you would like to say something?
I just wanted to add one more thing that I've learned over time in my own personal series, and that is that, and this is not a profound observation, but just a cautionary thing. In general, in my experience, younger patients do much better with surgery than older patients, specifically for thoracic outlet. And we published a small series of pediatric cases of TOS, and they're all terrific outcomes, much better than the middle-aged adults that you see. So kids, they don't have ulterior motives, they don't have secondary gain, they don't have workman's compensation issues and so forth. So if they have symptoms and you can diagnose them, they always have an anatomic feature, even if it's a pain syndrome, and you'll get them better. Young adults, in my experience, do much better than the middle-aged laborer who presents with what sounds like a post-traumatic or a repetitive stress type of presentation. So I'm now becoming hesitant to recommend surgery for the older group, middle-aged and older patients who seem to have a painful thoracic outlet. The young patients, in my experience, do much better. So that was my own.
Any other comment?
Eric, just something. I mean, I wouldn't be so critical towards middle-aged patients, you know? I mean, after all, we belong to the age group right now, so, you know.
All right, it sounded like age discrimination I was proposing.
Exactly.
I'm just giving you my experience, that's all.
No, Eric, but you are right. This is reasonable because if we assume that there is some anatomical abnormality or attitude, or it doesn't come when you are 60 or your 70s. It doesn't come when you are a young adult. So I think it is reasonable that younger people are more prone to have thoracic outlet than the other one.
Yeah. And much more likely to have cervical spondylosis as the cause of their neck and arm pain. in the older age group.
Yeah.
Are we approaching to our consensus remark, or we make some additional remarks or comments?
I think we are approaching.
So please conclude the meeting and let's make some consensus remark.
Can we consent that thoracic outlet syndrome is heterogeneous? Do we have a consent on that?
We have.
Okay. Great. First step taken. So as we consent in that, I think it's super huge that we have so many people here in this webinar with so much experience, because if you have this heterogeneity, you have to have experience, or you have to listen to people who did a lot of surgeries, because you cannot find everything out of the literature. So I think it was a very great thing to have all of you on board to be. Stefano.
Nora, I can say that there is no consensus only on the first three. Because no, listen, because clinic is clear. Deborah showed us, well, we have worked many years together, but Deborah has shown that imaging and the symptoms, we almost all agree that vascular maneuver like Edson, Halsted, and so on, leave the time that they find, that time to be decided, but there are other neurological which are better. So I think we have almost agreed on everything, and probably also on the first rib resection, provided that we distinguish between C7 and T1. Probably other people would like to perform first rib resection, like vascular surgeon who tend more to do this, but I don't think we are so heterogeneous, at least from the panel of today.
Anyone taken out a normal first rib in the panel?
In the
panel? No one?
You know.
Okay, so we have somewhat a consensus on that.
I think we have consensus almost on everything. Of course, it is heterogeneous and we can discuss only on the disputed cases, but whether we should wait, give them opportunity to wait and think about, or go to surgery. In my personal opinion, instead of having a stalker, I prefer 40 minutes of surgery. But of course, it is open to everyone's opinion, and is good also to help and not to open the door too much to a possible unuseful surgery, because in disputed TOS, you have the less percentage of result, of course, if compared with the rotative with abnormalities or atrophy.
Great.
There are a few things we can discuss, but for the majority, I am happy that we are all more or less in agreement.
So I think that's a good final word, isn't it? So thank you very, very much to especially to people from other time zones who were able to join us, but to all the others for preparing great talks and for having very, very good discussions. And I think our participants did profit from that very, very nicely, to hear the different viewpoints and to hear consensus and some controversies. All right.
And
great to see you all.
Yeah, and for
Great
my
to
side,
see you all.
The best. Thank you.
My side, just a few more words. Very much once again to all of you, and I'm very proud and very happy we are working together. No matter if it is live or Zoom, although I prefer live meetings, but generally speaking, we are now on the Zoom. Also very efficient, like we are also in our live meetings. I have a question for Eric. What about WNS and CNS congresses in United States? Are they ongoing or not?
They have all been delayed. During this past year, of course, it was virtual, but the Congress is planning to meet in the summer, the fall, I guess, and I believe the in person, and the AANS and the Academy are going to meet in person. I haven't heard yet about the ASPN, but I believe as of the end of the summer or early in the fall that there will be in-person meetings again.
Great.
Because all of us at least will be vaccinated by then, and hopefully the new variants will not be all resistant to the vaccines, which I guess is yet to be determined, right?
Yeah.
But the plan is to have in-person meetings as of late summer or early fall.
Excellent.
Lucas' passport is depressed.
Yes, also, and we are hoping that Hamburg meeting will also be live in person, and then okay, we'll see. Some housekeeping information for our next business meeting. We are planning beginning of March, as we discussed last time. Are you agreed that it will be let's say Tuesday, March 9, 4 or 5 o'clock p.m. Wednesday there are webinars, usually terms for webinars, and we can have a meeting on Tuesday, March 9, 5 p.m. for example. Are we okay with that? Perfect. Thank you. And at the end of March, we'll have our next webinar about controversies in entrapment neuropathies. And we are very happy that Kartik accepted to organize this webinar.
Madre, sto facendo un webinar.
There are some people who would like to join us. For example, like Michael Fox from Royal Orthopedic Hospital in London. We know him all, I believe, and we fixed the date. I think this last Wednesday on March. So we will be in preparation for this webinar. Of course, we will invite some other people if Patrick consider this to join us. And that's it. I'm very happy that we complete this section extremely successfully, like always. And we're always very happy to see all of you. So you see the comments on the chat. I would like to thank Anne. Anne, are you here?
Yes, I'm here. Thank you, Lucas.
Thank you very much for your support. And my kind request for you is that can you send us, you probably see the participants from all over the world.
Absolutely.
Not the names, but the countries, because I see that there are some participants from out of Europe.
Absolutely. I will share all the info.
Okay. Perfect. So, good day or good night.
Good night.
Good day or good night. All the best.
All the best. Thank you.
Thank you.
Bye.
Good night.
Bye-bye.
Buon appetito.
Ciao, Deborah. Ciao.
Ciao.
Thank you, Anne.
Thank you.